2023 is a place where minds are expanded, dreams are nurtured, and friendships flourish. I would request our scientific chairperson, Dr. Nilesh Parekh, to come and officially welcome all our delegates. Over to you, sir.
A very good morning to all, and I welcome all the delegates to Bhavnagar on behalf of IMA Bhavnagar and to the 75th HCG GIMACOM. I wish to thank all the speakers who have taken pain to prepare wonderful deliberations for us, and I assure you that all the sessions are very, very interesting and very informative. So please attend all the sessions, and without wasting any more time, I would like that we start today's proceedings. Thank you all and welcome all.
Thank you very much, Dr. Parekh. That was indeed the shortest welcome speech I've ever heard. So thank you for saving time and making our scientific deliberations elaborate. Thank you very much. Before any auspicious occasion, we would like to start with a prayer, because prayer is a hotline to God. It is a song of the heart. And like faith, a true prayer can move mountains. So let us all pray to the Almighty to bestow His blessings on this occasion. And to do the honors, I would request Dr. Kairavi Ben Joshi, our Swar Kokila of Bhavnagar, to come and present the prayer for today. As we all know, she is an enthusiastic member in the National IMA Cultural Committee as well. And for a short while, let us close our eyes and be one with God.
गणनायकाय
કૈરવીબેન, આપનો ખૂબ ખૂબ આભાર. આપે આજે દરેક હૃદયમાં આ પ્રાર્થનાથી એક એક દીપ પ્રજ્વલિત કર્યો છે. અને કહેવાયું છે ને કે ખૂબ આપ્યા છે જગે બુદ્ધિએ સર્જેલ પ્રકાશ. ખૂબ આપ્યા છે જગે બુદ્ધિએ સર્જેલ પ્રકાશ. આજે લાગણીઓના દીપ જલાવી લઈએ. તો આવા જ દીપ પ્રજ્વલિત કરીને આપણે આગળ વધીએ. મૂવિંગ ઓન ટુ our academic extravaganza for today. And to kickstart the session, we have our enthusiastic speaker and chairperson all set to keep the ball rolling. And we all know that winter is coming, especially because we are meeting on the Sharad Purnima. And if you talk about winter, cold and cough are like season's greetings. So to deliberate more, we have our chairpersons and speakers eagerly awaiting.
So to start the session today, the opening chairpersons, I would like to invite Dr. Rahul C. Dharane is a well-known physician practicing in a private since 35 years in Bhavnagar, and his special interests are cardiology, diabetes and clinical medicine. He is also currently associated as a AP in Sati Hospital. Dr. P.K. Bansal sir is MD respiratory medicine practicing as a chest physician in Bhavnagar since 1987. He has a special interest in asthma and COPD, and he is a member of all well-known association of India. He is also a member of Physician of India, Chest Physicians Association of Gujarat. And Chairperson sir, now the stage is yours.
To all, as the delegates are trickling in, let us start the morning session. My privileged duty is to introduce the speaker, whom most of us know. Dr. Maulik Sanghvi. He is a consultant pulmonologist in Bhavnagar in practice since 2010. A student and alumni of BJ Medical College, Ahmedabad, has worked at the prestigious Hinduja and Sir H.N. Hospital, Mumbai. And to his credit, he has 4 national and 1 international papers, and he regularly talks and is a loud orator. May I have the privilege of welcoming Dr. Maulik on the stage and to start his talk.
Thank you. So, good morning, all those who have come, and welcome, and good morning to all those also who are having the breakfast. My humble thanks to the organizing committee, Dr. Reddy's, for supporting this academic session, and esteemed chairpersons. At the outset, I would like to first emphasize that why this topic is so important. Everybody of us, every day, when a doctor tag is attached to our names, then this type of patients start coming to us. It's not just only physicians, pulmonologists, pediatricians, or anybody non-surgical branches. Even for the surgical branch doctors, phone call comes, Mama, ટીનુને બહુ તાવ ઉધરસ ને શરદી થઈ ગયા છે 3 દિવસથી, તો હવે શું કરું? So that Mama, if he is even a gynecologist or an orthopedician or anybody, he has to treat, right? And today when we are standing over here after the COVID pandemic, we know that fever with coughing has its own stages. A stage before a deadline, the patient will be 100% curable, and if we go beyond that, we may lose the patient, right? So it is so important, and it contains multiple entities under it, and we try to evaluate and simplify all of them and see a staged approach to it, right? So first is, what is persistent pyrexia? That is the primary thing that we should define. So any fever with patient's body temperature more than 103 for more than 3 to 5 days, that is more important, right? The fever, now the studies say that the fever 103 may vary from patient to patient. So we let go the 103, but fever is mandatory. If we need to label it persistent pyrexia, then patient should have fever at least for 3 to 5 days, right? Then it is something very significant, right? So first, of all, we need to decide as a doctor, as a treating physician, that is my patient really having fever, right? Because some patients are, ઘરે તાવ આવે છે, અહીંયા કાંઈ નથી. So we need to know whether actually we are dealing with fever or no, right? So some points would help us like malaise, headache, weakness. Those would be associated with fever usually, right? Then one more point which always would be associated or mostly would be associated with is tachycardia. So by that we can realize or we can finalize or we can decide that okay, the patient is having some inflammatory process going on in his body, right? Now, first 3 to 5 days, 95%, by 95, I actually mean 95% of patients get cured before this period. So we just don't need to worry firsthand if a fever patient comes or if a fever patient has coughing with it, right? But now in our OPD or in our day-to-day practice, we get two type of patients. One type is very good. We like, all of us like, સાહેબ 2-3 દિવસથી તાવ આવે છે, આ કર્યું તે કર્યું, ઓલી દવા લીધી, ફેર નથી પડતો. So now the job is easy for us. We give some medicines and in 1 or 2 days, that 3 to 5 days deadline is crossed and patient starts improving. So easy. But then other type of patients are, સાહેબ 5 વાગે તાવ આવ્યો ને, 6 વાગે હું આવતો રહ્યો. So that 1 hour the fever is right. He has a fever. But only 1 hour has passed. So now we need to pass 3 to 5 days for him with his apprehension, with the relatives' apprehension, right? So we need to explain him, assure him that by 3 to 5 days wait કરવું પડશે, દવા લ્યો, gradually it will improve, right? So assurance and symptomatic treatment is what we do. Plus we keep a keen eye on associated symptoms because we never know which way the patient will go, right? So after 3 days, 3 days has passed, the fever has continued. Now what? Right? So start thinking in your mind. We still don't need to tell anything. Sometimes fever goes away and coughing starts. Sometimes fever goes away and gross pedal edema develops. Then sometimes some sporadic infections like lepto, scrub, etc. may be there. Then there is PUO, again a big topic. And there are some multiple rare causes like malignancy which may sometimes cause fever. We need to just keep them in mind. Each of them has its own discussions, but what we focus on is persistent fever with non-resolving coughing. So our associated symptom over here with fever is coughing. So patient by default has fever 1, coughing 2, right? So now we go case wise because all of us over here are clinicians, so that would be a better approach. So 50-year-old, 52-year-old male patient, right, presents with 7 days of fever with coughing, 3 to 4 days. No pre-existing other disease, associated symptoms, breathlessness on mild exertion, and on auscultation, bilateral scattered crepitations plus. So now, 7 days of fever. So we need to think that something is going on. This is not normal. This is not simple viral which will resolve by itself, right? So possibilities start coming in mind, and then we detailed or basically investigate. See, we will be only basic. We don't go in the ICU and all the detailed investigations. We remain basic. So SpO2, we measure 91. So again, a red flag, right? Blood investigation, total count 4100, CRP 185, D-dimer, LDH, normal. So next is chest X-ray, our favorite. We chest physicians love chest X-rays because it helps us a lot. So when we do a chest X-ray on 7th day of fever with coughing, we get this. Patient has come walking, SpO2 91. So now what? Yeah, you'll have to answer me after some while. Still I am saying. So we go for a HRCT. Naturally, if this is a chest X-ray, we need to get an HRCT done. And this is the HRCT, right? So we get a throat swab done. And mostly it would be a viral pneumonitis, right? This, all of us have seen these type of X-rays and CTs in 2021 and 22, right? So this is a viral pneumonitis which can present with fever and persistent pyrexia. So what are the treatment basics? These are not for this patient, these are the basics. That any one antibiotic we give basic but covers a big spectrum like doxycycline, azithromycin, or it depends on the choice. It can be Septran, it can be anything, upon the treating physician, right? To cover the secondary bacterial infection, because the lung has already been affected by the virus, right? Paracetamol, multivitamin, and supportive treatment for viral infection. Rest and good hydration. Watch for desaturation and tachypnea. Role of steroid is stage dependent, we all know. And finally, if the patient is deteriorating, then we need to get him admitted and go for the further treatment, which will be seen by the intensivist, right? So this is one case we see very frequently. Second, a 3-year-old child, a female child, a girl, small girl, presents with 12 days of fever with chills and coughing, progressive, not relieved by local medicines. We don't have any details of that. Associated symptom, as I said, it is most important. We always need to keep an eye on associated symptoms. So associated symptom is right-sided pinning chest pain, and child is more comfortable sleeping in the right lateral position. So something would be coming in your mind, right? Yeah, so that is what we want. No history of cyanosis or edema, child, so we have to see that. And air entry is decreased in right mid zone and lower zone, right? So almost we are clear that, okay, we are dealing with something which is in everybody's mind. So, but we cannot just go by that now in today's day. We need to label it, we need to stamp it. So what next? We get an SpO2, normal, blood count 14,100. See, I have mentioned only the investigations which are abnormal, and I have not taken any special investigations in consideration, because we are dealing with a first call fever with pyrexia with coughing patient, right? So CRP is 84 and sugar is normal. So again, chest X-ray, our favorite, and this is the chest X-ray. So now we know what are we dealing with, right? But still we cannot label it, so we need to go one step ahead. So we get a USC guided diagnostic tapping done, right? And when we go for the tap, what we get is this. This is an actual patient which we treated just before few months, and so this is what we got. And so what is it? Empyema, right? So empyema is another category of diseases where the infection may last longer, fever with coughing may be the presenting symptom. So treatment basics, right? So before was this X-ray which we saw. So what is the treatment for empyema? Chest tube insertion with antibiotics according to drug sensitivity, right? So we inserted a tube, this is a tube seen, and then after 5 days the tube was removed, and after 10 days the patient was followed up, and what we got was this, right? So it is a very treatable cause. When treated on time, it saves patient's life or patient's lung, or saves the patient from going into a big surgery like decortication or something like that. And this was a child. A similar presentation can be with an adult also, right? Okay, next. Now see, again, make your minds alert. 42-year-old female patient, right? Presents with 10 days of fever and cough. Associated symptom is joint pain with swollen hands and hand and feet joints, right? So something coming in your mind? Yeah. So history of, again history is important, history of multiple similar episodes in past plus, right? But somebody treats them, some antibiotics, some anti-inflammatory, and patient improves. And again presents with similar episodes. So now the patient comes to you that we need to get some diagnosis, right? So on auscultation, typical bilateral lower zone fine inspiratory crepitations are heard, right? So something may be coming into mind. So what next? We measure an SpO2, 99% room air, right? CRP is 101, RA factor is 98, and anti-CCP antibodies is 66, which is normally around 20 or 18, right? So we get a chest X-ray done, right? And this is the chest X-ray. A female patient, 42 years old, joint inflammation, swelling, and anti-CCP 66. So we have the diagnosis, right? So we get a CT done. I'm not going into the CT patterns because this is basically rheumatoid arthritis with lung interstitial involvement. Now a word about that. It is an inflammatory condition. It can cause fever, and the interstitial lung involvement has multiple patterns in HRCT thorax, but we don't go into that because it is again a big topic for discussion. But these two are very closely associated. Now as the CT scans and as the awareness has increased, we know that so many rheumatoid arthritis patients have UIP, or the interstitial lung disease, or the pulmonary fibrosis, whatever we may call, depending upon the pattern. Two things about that. One is that, this is out of the way. One is that if the patient is having pulmonary fibrosis associated with rheumatoid arthritis, the prognosis is very, very good, rather than patient having only pulmonary fibrosis, right? This is one point. And second point, just like diabetic neuropathy, pulmonary fibrosis in rheumatoid arthritis can present before the joints are affected, right? So even if you are treating a patient of pulmonary fibrosis or ILD, you need to keep in mind that later on, after 2 years, 3 years, if the patient is developing joint associated symptoms, then it can be RA with ILD, right? So ILD develop first, RA later. That is also a possibility. Okay. So approach. Steroid and methotrexate, see, whatever rheumatologists give is in our favor. So we need to treat less as a pulmonologist, I am telling. Right? So steroid and methotrexate or any other immunomodulator, rheumatologist will give. That will help even pulmonary fibrosis. Then antibiotic and supportives, if exacerbation, if patient has exacerbation. Perfenidone and nintedanib, they both are antifibrotics, proven antifibrotics, but for RA-associated ILD, only if it is an advanced stage, right? Then sildenafil, tadalafil or bosentan, if increased PAH is found. But again, PAH has 5 categories, and these molecules are not very much proven, still studies are awaited, very much proven for ILD-associated PAH, but we are getting good results. So if the patient is not improving, we can add these, any of these 3, right? And N-acetylcysteine also is believed to have some role in some patients. Okay. So now, these type of patients do have a cough which is not resolving easily, and we don't have much to do for them. So these are the basic cough preparations. As such, in day-to-day practice, we need to use this. So these are the approved cough preparations by the government, which we can use safely, and it won't cause any issues, right? So it is for dry coughing, productive coughing, coughing with bronchospasm, coughing with cold and fever, and common cold, right? So except dextromethorphan, we can use any of these in anybody. And for dextro, it has to be a child if it is more than 4 years, right? So these can help in ILD-associated coughing if nothing else is helping. We need to somehow help the patient out of his symptoms, right? So, yeah. Okay. Now, I'll be asking you more and saying less. So this is a 30-year-old male patient, right? Presents with 20 days of fever with cough. That is our topic, right? So associated symptom. See associated symptom importance. We need to ask. If patient tells, good. If he or she doesn't tell, we need to get it out from him. Weight loss of 7 to 8 kg. Yeah, initially it was 55, which has come down to 47. So it is like more than 10% of his body weight reduction, right? So on auscultation, left upper lobe crepitations. So I think something must be blinking in your mind, yeah? So what next? SpO2 normal, right? Hemoglobin 8.8, total count normal, ESR 102, CRP 100, right? Again, going towards diagnosis, we get a chest X-ray, and this is the chest X-ray, right? So sometimes we are reluctant in getting chest X-ray done for a patient, but chest X-rays help a lot. That's what I have seen, right? So, but okay, still we don't end over, we stop over here. We get a sputum CBNAT, right? Now government has put up a lot of schemes where even we as a private practitioners can get a CBNAT done for any patient free of cost in government, which is quite reliable. For CBNAT, I rely more on government reports than private reports. That is my personal observation. So we get a CBNAT done, and this is what we get, right? Mycobacterium tuberculosis detected, and RIF resistance not detected. So both are good enough for us to start the treatment, right? Now a word about this, that RIF resistance, why is it important? Because rifampicin resistance is associated with 88% of all the MDR TB cases. So if rifampicin is sensitive, 88% chance that we are dealing with a drug sensitive tuberculosis, and if somehow rifampicin is resistant, we cannot go further without getting a culture and a drug sensitivity done, because the patient may be MDR TB. Sir knows better. So this is sputum CBNAT and MTB and rifampicin resistance. So this is a pulmonary tuberculosis clearly with cavitation. Now I won't go in any detail about the treatment of tuberculosis, because everybody knows, probably most of you know better than me, tuberculosis treatment. But one word about treatment. See, in every stage, diagnosis, treatment, in the diagnostics, the treatment, medicine availability, every way we have improved in fighting tuberculosis. But a small glitch which I see, and I'm trying to point out, is that even the medical store people, if we prescribe, and if we don't write anything, they write XYZ tablet for TB, bhukya pete levi, right? Now, tuberculosis, any medicine does not be given. It is not necessary to give any anti-tuberculous medicine empty stomach. This is not my statement. This is said by our beloved Lancet journal, that the last statement is that it is therefore unnecessary to insist that rifampicin in a single dose 600 mg has to be taken fasting. Right? So it is not necessary. So, and other medicines obviously are not to be given fasting. When we used to give separately all the medicines, we used to give rifampicin alone fasting and other all after food. But now we are using drug combinations, which is good. And so everything was fasting. Now, for us to write is easy. But a patient taking pyrazinamide 1500 mg empty stomach, he is bound to get default, right? So this is a backup of our statement that we don't need to give any anti-tuberculous medicine empty stomach. We can give all the anti-tuberculous medicines after food, and the tolerance would go 70% higher, right? So this is only thing which we need to see about anti-TB treatment. Rest everybody knows everything. Okay, so now my job is done. Now we'll have an interactive session. So please tell, what do you think about it? Fever with persistent pyrexia is there. I'll give one hint also. True, sir. So it is miliary. It is an infection because patient is having fever. So the patient is relative of the previous patient, which we saw, and staying in the same house, right? So that is the hint. It is miliary tuberculosis, right? So perfect, sir. Good. Okay, next. Okay, what is? Hint. See, there is a peculiar lobar distribution with air bronchograms visible, right? So it is a lobar pneumonia or a community acquired pneumonia. Usually, so this is usually we cannot rely on it, but just for a thought process and how to proceed further, pneumonia or a bacterial pneumonia does respect the lobar margins, while a tuberculosis has no bounds. It can spread in any direction, in any shape. It can give a cavity, right? So this is a CAP. Pardon, sir? True. Okay. So, easy. Okay, perfect. So this patient is an alcoholic. right? So alcoholics are predisposed to lung abscesses, and this is a typical slide for that. Lateral we used to do, now we are not doing CT directly, right? So what is this? Perfect, perfect, please shout. Yeah, so this is CT of that. Hint is that these type of patients have fever only during an exacerbation. Otherwise they don't have fever, because our topic is fever with cough. And it is bilateral extensive bronchiectasis. Even if we get it from X-ray, we need to get a CT done. Right? Okay, this is the last one. Physicians dealing with seropositive patients. Yes, fungal. Which fungal? PCP, right? Pneumocystis jirovecii. A typical characteristic battering appearance where the lower angles are spared. See, these parts are spared in it, but this whole middle and upper middle is affected, right? So this is a PCP pneumonia, typically found in a seropositive patient. Again, doxycycline or Septran, they give excellent results along with antifungals, right? So this is all. I would like to end with this very prestigious and we need to, I follow it. It is from Harrison's Principles of Medicine, Internal Medicine, that think of a common disease, you will be commonly right. Think of a rare disease and you will be rarely right. Thank you so much.
Thank you, Dr. Maulik Bhai.
Hello. Thank you very much, Dr. Maulik Bhai. You had elaborated in a very useful way, which will be of use to all the consultants.
Thank you so
and the general practitioners. Thank you.
Just, sir, please stay on there. I would like to request the chairperson, sir, to honor the speaker with the memento.
We are an intelligent audience, but I think the speaker deserves a round of applause.
Now I request our President, Dr. Jadeja Sahib, to honor both the chairperson who have done their job perfectly.
So moving on to the next session, we will invite the chairpersons.
Chairpersons for this session are Dr. Umang Desai and Dr. Kunal Mangle. Dr. Umang is a practicing oncosurgeon in Bhavnagar. He has done his MBBS and MD from the BJMC and working in Ayush Cancer Hospital since 2003. And Dr. Kunal has done his DNP in surgical oncology and his experience for more than 8 years and working as consultant surgical oncologist at HCG Bhavnagar.
So the speaker for our today's session is Dr. Aditi Bhatt. She is MS-MCH in surgical oncology and she has been working in KD Hospital, Ahmedabad. She is an Indian surgical oncologist who specializes in the management of primary peritoneal malignancies and secondary peritoneal metastases of gastrointestinal and gynecological origin. Her key areas of research are surgical therapies for ovarian cancer, outcomes of surgical treatment of peritoneal metastases in the Indian subcontinent, and the pattern of peritoneal dissemination in various primary and secondary peritoneal malignancies. She is a founding member and the secretary of Society of Peritoneal Surface Oncology India and a member of Executive Committee of the Peritoneal Surface Oncology Group International. She has published more than 75 research papers and edited 2 books on the peritoneal surface malignancies. So we welcome Dr. Aditi Bhatt.
So from a very common malignancy, we move on to something that is very rare even in oncology. And I'm one of the few surgeons who exclusively wants to practice peritoneal surface oncology. The presentation? So, till not very long ago, peritoneal cancer was stage 4 cancer. It was considered incurable and it was just treated with systemic therapy or palliative care. And I'll begin with the example of this patient. So this is a 53-year-old lady she came to me in 2014, and 8 years before she came to me, she was diagnosed with this rare peritoneal tumor called pseudomyxoma peritonei. Essentially what happened is there was a jelly-like substance that was filled in her abdominal cavity. She had abdominal distension. So what her local surgeon did was put a small incision, remove all the jelly, and she would be relieved of all her symptoms. And this kept on going for 8 years. Every year the jelly would fill up and she would feel uncomfortable. The surgeon would remove the jelly and then she was comfortable for a year. After 8 years, she reached a stage where she developed subacute intestinal obstruction and she was nearly bedridden. And that is when her son looked for options for treatment of pseudomyxoma peritonei and came to me. In that condition, we operated on her, and you can see to the left, pointer. So this was the scan when she came to me, and there was disease all over her abdominal cavity. We removed most of the tumor except this nodule, which we removed 6 months later. And then she went on to be disease-free for 3 years. She eventually died 5 years after my first surgery, but till she died, she was asymptomatic. She died of lung metastasis. So this is what we could do when the patient came to me 8 years after diagnosis. If she had come to me at the beginning, she would have probably been cured and still be alive. So this is another patient, and once again this is all the tumor and this is what we can do, remove the whole tumor. Here we remove the entire colon and even the stomach. So what is peritoneal cancer? We all know that it is stage 4 disease, but there are 2 cancers at least that I know of in which peritoneal spread is not stage 4 disease. In ovarian cancer and peritoneal mesothelioma, peritoneal spread is present in all stages. And peritoneal disease as compared to other metastases is considered to be more aggressive. It is more aggressive. If you have liver metastasis or lung metastasis, they are less aggressive. Those patients live longer as compared to patients with peritoneal disease who have a shortened survival. And this is mainly because peritoneal disease leads to fluid buildup in the abdominal cavity or ascites, intestinal obstruction, and greatly brings down the quality of life of the patient. So as we surgeons who treat peritoneal disease, we divide peritoneal cancers into primary and secondary cancers. The primary peritoneal cancers are peritoneal mesothelioma and primary peritoneal cancer that is treated just like ovarian cancer. Secondary peritoneal cancers which arise from inside the abdomen, and those are the cancers that we can treat with a curative approach. Colorectal cancer, ovarian cancer, gastric cancer, and appendiceal cancer. Then there are some rare tumors that spread to the peritoneum: lung cancer, breast cancer, malignant melanoma, and we don't treat them with a very aggressive approach. The approach essentially in these patients is palliative. So the conventional approach, and in India this was a reality just about 10 years ago, these patients were just treated with systemic chemotherapy. They lived 6 to 9 months. With the modern chemotherapy regimens, they might survive 2 or 3 years. What we do is we treat them with cytoreductive surgery with or without some form of intraperitoneal chemotherapy, and they will live at least for a few years, and some will also get cured. So this is how we treat them now. Now it's not just surgery, but we use surgery in combination with chemotherapy. If you see, these triangles are for the surgery and these lines are for chemotherapy. So there are few cancers that are treated with surgery alone, whereas most of the peritoneal cancers are treated with a combination of surgery and systemic chemotherapy. Surgery can be combined with intraperitoneal chemotherapy. For palliative patients also, where we know that we cannot remove all the tumor, or even if we manage to remove all the tumor from the peritoneal cavity, they are not going to be cured, we add intraperitoneal chemotherapy. And intraperitoneal chemotherapy, when combined with the conventional chemotherapy, produces a better response, a more durable response, and sometimes makes these inoperable patients operable. So what is the curative intent treatment of peritoneal cancer? The backbone of curative treatment of peritoneal cancer is something we call cytoreductive surgery. Cyto means tumor cells, reductive is to reduce, and essentially the goal of this surgery is to reduce the tumor cells to zero. It is not debulking, the goal is no visible residual disease. And cytoreductive surgery comprises of peritonectomy procedures and visceral resections. We do all kinds of peritonectomies, right upper quadrant, left upper quadrant, omentectomy, greater and lesser, parietal peritonectomies, pelvic peritonectomies, and even the small bowel and large bowel mesenteric peritonectomies. Visceral resections, depending on the viscera that are involved, we commonly remove the gallbladder, appendix, spleen, segments of the intestine, the stomach. Rarely, if required, depending on the disease and the tumor biology, maybe segments of the liver, pancreas, ureter, and bladder. So this is what it looks like. Most of the times it is maximally invasive surgery. The scope of minimally invasive surgery in these kind of surgeries is very limited even now. And this is what you might end up removing in one surgery. So this is a short video of what it looks like once we've removed all the disease. This is the pelvis, this is the bladder, this is the ureter. We've removed all the peritoneum in this patient of ovarian cancer. Here you can see the colon is completely mobilized. This is the abdominal wall. I hope there are some surgeons in the audience. This is the left diaphragm. The spleen is completely retracted. There is the spleen. We preserve the spleen in this patient. The whole parietal peritoneum has been removed in this patient. That's the stomach, and the greater omentum has been removed. Now you will be seeing the transverse colon. This is what a proper total omentectomy looks like. This is the periportal region. Even when there is disease at the liver hilum, with our specialized techniques, we are able to remove it completely. This is the stomach. The lesser omentum has been removed. That is the area of the right kidney, and that's the liver completely mobilized. And there you can see the right diaphragm. There was a rent in it which has been sutured. That is the inferior vena cava. That is the duodenum and the head of the pancreas. And that's the porta once again. So essentially, any amount of disease can be removed from the peritoneal cavity, provided not much of the bowel has to be sacrificed and some critical structures can be preserved. Here we've removed the liver capsule as well, because the capsule was involved with disease. So this cytoreductive surgery is often combined with intraperitoneal chemotherapy. And now the question is, why do we need intraperitoneal chemotherapy? So briefly, these are all the types of intraperitoneal chemotherapy, and today I'll be talking just about two of these techniques. One is HIPEC and the other is PIPAC. Why do we need intraperitoneal chemotherapy? Because systemic chemotherapy does not reach the peritoneal tumor adequately. The microcirculation is poor and the drug does not concentrate into the tumor nodules. When we give chemotherapy intraperitoneally, it directly reaches the tumor and the intratumoral concentration is more. More importantly, most of the patients with peritoneal disease have bad disease biology. And so we hit them both systemically and intraperitoneally. There are some other advantages of intraperitoneal chemotherapy also, which I'll just explain. The most commonly used intraperitoneal chemotherapy even now is HIPEC or hyperthermic intraperitoneal chemotherapy. It is given in the operation theater at the time of surgery. We remove all the tumor and then we perform HIPEC. What we do in HIPEC is that a heated chemotherapy solution is circulated in the peritoneal cavity for 60 to 90 minutes. And this is what it looks like. There is an inflow, it circulates, it comes back into the machine, it gets reheated, and this perfusion is very important for us to remove the residual cancer cells. So the rationale is that chemotherapy is given directly to the tumor. Heat itself is cytotoxic and it potentiates the effect of the chemotherapy drugs, and perfusion prevents reimplantation of tumor within the peritoneal cavity. So when you do a cytoreductive surgery, the peritoneum is full of tumor, and when you're handling the peritoneum, some tumor cells will be shed at the time of surgery itself. If you do not do this type of intraperitoneal chemotherapy, then there is a possibility that these tumor cells will implant at your surgical site. And it is a huge raw area. You just saw the raw area that is created during surgery. The next type of intraperitoneal chemotherapy is called PIPAC or pressurized intraperitoneal chemotherapy. As opposed to HIPEC, it is not used with cytoreductive surgery, and in colloquial terms, you could call it a chemotherapy spray. So what we do is we take lap access. This is delivered by laparoscopy. We take the peritoneal biopsies, evaluate the disease extent, and then a pressure injector is used to convert the chemotherapy solution into an aerosol. And this aerosol is supposed to penetrate the tumor tissue better than a liquid solution. Multiple applications of PIPAC are possible at 4 to 8 weeks interval, depending on which tumor we are treating and whether we are using systemic chemotherapy with it or not. PIPAC is currently used for patients who are unresponsive to systemic chemotherapy. So if you have a patient with peritoneal disease, you've given 1 line of chemotherapy, 2 lines of chemotherapy, the disease is not responding. In some of these patients, PIPAC can prove to be a boon. It can make the disease respond, control the ascites. So patients who have refractory ascites, patients who are not willing for chemotherapy, if they've had intolerable side effects or the limit of systemic chemotherapy has been reached, and many times now we are using it in combination with systemic chemotherapy to produce a better response. We also have an Indian device that is called Nanozol for aerosolized chemotherapy, and it's available at 1/5 of the cost. It has many other improvisations, and we are going to start phase 1 studies on this soon. And this is what it looks like. You can see this aerosol that is being sprayed laparoscopically. So the difference between HIPEC and PIPAC, HIPEC essentially is a one-time treatment. It has more side effects, but it is more effective because it's combined with cytoreductive surgery. PIPAC, on the other hand, is mainly used for palliation. So the big question, do all patients with peritoneal cancer benefit from the cytoreductive surgery and HIPEC? Obviously not. Many a times we get patients in a very late stage who've been inadequately treated or inappropriately treated, or the disease is such that no matter what we do, we cannot treat them with surgery. However, we can make a huge difference to some of these patients, and the ones that benefit most are those with pseudomyxoma peritonei. That is a rare cancer that arises mainly from the appendix, patients with peritoneal mesothelioma, ovarian cancer, colon cancer, and stomach cancer. These are the 5 main cancers that we treat, and these are the reported survivals. For pseudomyxoma peritonei, median survival is 16.3 years. You consider stage 4 cancer and the patient can live for a median of 16.3 years. For peritoneal mesothelioma, 50 to 60 months, that is nearly 5 years. Advanced ovarian cancer, 40 to 50 months, and if the surgical approach is more aggressive, more than 50 months, again, patient who's coming with ascites with widespread peritoneal disease is living for 5 years or more. Colon cancer, not a little bit less, but stage 4 colon cancer, the average survival was less than 2 years. Now it's being pushed more towards 4 years. Gastric cancer, not so promising, 60 to 30 months, but still better than what can be achieved with systemic chemotherapy alone. And these are our Indian results. We are catching up with the Western data. Appendix 88 months, ovarian in the 40s, mesothelioma 44 months, and in some rare tumors 60 months. So we have a lot of our Indian data also, some novel techniques like removing the entire peritoneum in ovarian cancer, using taxones for PIPAC, which has not been used before. And we published some guidelines with the international groups also. So another important thing that I would like to touch upon is the prognostic factors for this surgery. One is the peritoneal cancer index. Now, this is a score based on the extent of disease in the peritoneal cavity. We give a score of 0 to 39 based on the evaluation of 13 different regions of the peritoneal cavity. And it has been shown that the lesser the score, the better the survival of the patient. Obviously, if there is less disease, the patient will live longer. But even in some patients with high volume disease, we can achieve good results, as you can see here. If you see this curve, sorry for the pointer, the curve to the right, to the left, it is still touching 2 years. The next important factor is the completeness of cytoreduction. We undertake this cytoreductive surgery only in patients in whom we can remove the tumor completely. If we cannot remove the tumor completely, this surgery is not undertaken, and the survival in patients who have residual disease measuring more than 2.5 millimeters is similar to what is achieved with systemic chemotherapy alone. So these are the goals of surgery for different diseases. For certain cancers, we need to have no residual disease, but for certain other cancers, minimal residual disease is also okay. And then the other factor that is receiving a lot of focus now is disease biology. So we prognostify patients according to molecular markers. If the disease biology is more aggressive, they get chemotherapy first. If it's less aggressive, they are treated with surgery alone, maybe in a few cases. And when we select patients for surgery, all these factors come into count. What is the extent of peritoneal disease, probability of complete surgery, is there extraperitoneal disease, what is the tumor biology. Another important thing for this surgery is the setup. It's not just the surgeon, you need the OT setup, you need very skilled anesthetists, you need an ICU that can manage these patients post-operatively, you need rehabilitation and all those facilities. And the important thing is the patient's general condition itself. If the patient comes to us in a poor condition, where they are not able to walk, they are obstructed, they have ascites, then those patients obviously cannot be taken up for this surgery. So what I want to say is that extensive disease is a relative term, and these are surgeries that need to be performed by specialists. What is extensive disease for one surgeon is easily resectable for another. This is one example. This disease is completely resectable. And this is another patient who has now been living for more than 10 years. When she came to me, she had already had 3 surgeries. Despite that, we were able to remove all the tumors. She had subsequently 2 more surgeries, and she is still alive. This is another 24-year-old lady who came with malignant mesothelioma and who survived 10 years with 2 surgeries. The maximum benefit of this treatment is seen in ovarian cancer. For every 10% increase in maximum cytoreductive surgery, there is a 5.5% increase in overall survival. And when you add HIPEC to good cytoreductive surgery, there is a gain of 1 year in overall survival, which is huge in oncology. Most of the oncological treatments are approved based on a benefit of few months only. Just a last word regarding the morbidity. It has been shown that the morbidity of this surgery is now equivalent to the morbidity of all major cancer surgeries. Same for the mortality, and these are some of the complications that we try to avoid, mainly the gastrointestinal complications. The major complication rate is around 20 to 30%. And the mortality less than 1% in experienced centers. For the less experienced center, and this is when we were less experienced, our mortality was around 2 to 3%. So what we do nowadays to reduce the morbidity and mortality is rehabilitation and enhanced recovery after surgery. And you can compare these curves. The red curve is a patient who has had rehabilitation and ERAS, and the blue curve is a patient who has none of it. Look at the difference in the recovery. So to conclude, peritoneal surface malignancies can be treated with a curative intent with CRS and HIPEC, resulting in a survival of over 5 years with good preservation of quality of life. There are many palliative options like PIPAC or other forms of IP chemo for those not eligible for CRS and HIPEC, and early and timely specialist referral is essential to obtain the best results. Most of the times these patients, when they come to us, they are told that nothing can be done, it's stage 4 cancer. I would urge everybody not to do that anymore, because so long as there is hope, there is life, and we can surely do something for most of these patients. Thank you.
Thank you, Dr. Aditi, for a wonderful presentation. As a cancer surgeon, I know that it is one of the most difficult malignancies to treat. But with advent of cytoreductive surgery and HIPEC treatment, it has changed the scenario of these peritoneal surface malignancies. Thanks a lot.
Thank you, chairpersons. We would now invite you to felicitate Dr. Aditi Bhatt for her wonderful presentation. I would like to call upon the President of IMA Bhavnagar, Dr. Devang Pawar, to do the honors and honor and felicitate Dr. Umang and Dr. Krun. Thank you, Dr. Pawar, for the honors. Dr. Aditi rightly spoke about hope. So carrying that forward, we need to learn that there's never loss of hope. We are born with the ability to change lives. And let's not waste it, because when there is an organ donor, life springs from death, sorrows turn to hope, and a terrible loss becomes a gift. So moving on to the next session on organ transplantation, I would request Dr. Kailash Bhalani to take it forward.
For the next session, our chairmen are Dr. Samir Shah and Dr. Jagdish Rana. Dr. Samir Shah is a general surgeon and laparoscopic surgeon in our Surti Hospital, Bhavnagar. He is also professor and head of the Department of Surgery and a president of Association of Surgeons of Gujarat chapter. Dr. Rana is a general surgeon and working with NHL Medical College Ahmedabad, from NHL Medical College Ahmedabad, and his area of interest is open high risk general surgery, burns, toxicology and surgical ICU care. I request chairpersons to take over, please.
Good morning, everybody. I would like to invite Dr. Diwakar Jain. He is a surgical gastroenterologist, fellow in hepatopancreatic biliary surgery and liver transplantation. He is a senior consultant. He is affiliated to KD Hospital, Ahmedabad, with an experience of 12 years in living donor and deceased donor liver transplant, ABO incompatible liver transplants, pediatric liver transplants, and all kind of complex liver, gallbladder, biliary and pancreatic surgery. His core interests are transplant and pancreatic surgery. I now hand over the podium to Dr. Diwakar Jain, please.
So today, in the first talk we discussed about the common diseases. In the second talk, we had some idea about the liver surgeries, and now we'll go into the core liver surgeries, and which is liver transplant. I hope that most of us are now getting patients with liver cirrhosis and who have queries about liver transplantation. So in this talk, we'll be talking about these queries. The first slide, my presentation starts with a pictorial slide. On the left side, there is a 9-year-old girl on ventilator in hepatic coma on dialysis with ammonia levels of more than 150. And on the right side, there is a 70-year-old old gentleman with decompensated liver cirrhosis. So our question is, which patient is fit for a liver transplant? Which patient would you select for a liver transplant? Right, so all these questions we'll try to discuss in our presentation. And the topic is decoding liver transplantation, when to operate, how to prepare, and what comes next. So before going to liver transplantation, a few refreshing our knowledge about few topics about related to liver cirrhosis. Three things which I would like to discuss. One is what is liver cirrhosis, second is what is compensated liver cirrhosis, and third is what is decompensated liver cirrhosis, right? Most of us know about it, just a quick refresh. We all know that liver is a remarkable capacity to regenerate, but repeated injuries to the liver leads to liver regeneration with scarring, right? And the healthy liver tissue is ultimately replaced by the scar tissue, and that is cirrhosis. So cirrhosis is basically progressive deterioration of the liver functions over a long term due to a continuous process of inflammation, destruction, and regeneration of liver parenchyma leading to fibrosis and cirrhosis. Causes, most common cause we all know, alcohol. Even in our dry state, Gujarat, alcohol is the commonest and lead cause for liver cirrhosis and liver transplants. Second front runner is non-alcoholic steatohepatitis, or also known as NASH, previously known as fatty liver, a very innocuous term but very dangerous now. And other causes are hepatitis B, C, Wilson's disease, autoimmune liver disease, Budd-Chiari. In pediatric patients, biliary atresia and metabolic causes are the common causes for liver cirrhosis and liver transplantation. Coming to compensated liver cirrhosis. So compensated liver cirrhosis is incidentally detected liver cirrhosis. Patient does not have any symptoms or just mild symptoms, non-specific symptoms like tiredness or reduced appetite. And so then what is decompensated liver cirrhosis? Decompensated liver cirrhosis is, it's when the patient starts developing symptoms or clinical features because of liver cirrhosis. And most common symptoms are jaundice, hematemesis or blood in vomit, deranged kidney function test, blood in stools or black stools, tremors, pedal edema, and altered senses of forgetfulness, also known as hepatic encephalopathy, which happens because of rising ammonia levels. So not going into details right now, the basic question that we want to address today is what is liver transplantation. In one line, if I would say, liver transplantation is replacing a part or whole of diseased liver with a normal functioning liver. That is, in nutshell, liver transplantation, although it is not as simple as that. And it is done in two ways: diseased donor liver transplantation, also known as cadaveric liver transplantation, and a second is living donor liver transplantation. Diseased donor is where a brain dead donor the family decides to pledge his or her organs, and you get a whole liver, that is diseased donor liver transplantation. Living donor is when a related family member donates a part of the liver to the recipient, and that is living donor liver transplantation. So the first question that we would address is when to transplant. When to transplant, when the question arises, the first thing that arises is decompensation and complications. So we previously saw what is decompensated liver cirrhosis. This table shows the survival data of patients of liver cirrhosis without transplant. So patients with compensated cirrhosis who do not have any symptoms may go on to live on an average for 9 years without needing a transplant. But when the decompensation happens, when the clinical features appear, then the survival outcome, without transplant comes down to on an average of 1.5 years. And when the complications start coming up, like spontaneous bacterial peritonitis, hepatorenal syndrome, the survival comes down to 6 to 9 months. And then there is a serious complication called HRS type 1, where you need to go in and do an urgent transplantation. Another factor that comes to mind when we discuss the question of when to transplant is MELD score and child score. These are common scoring criteria which are available online also, and they are based on the blood investigations and the clinical symptoms and signs in the patient. And this is the only this is a data slide where they studied a number of patients who underwent cadaveric transplant, and they found that as the MELD score increases, this is the importance of MELD, as the MELD score increases, the transplant free survival, it gets worse compared to survival with transplant. So patient of MELD score 10 probably would do better without transplant. But as the MELD goes beyond 14 and 15, he or she would require transplant to get a better survival. So in nutshell, think of transplantation when there is decompensation, there are complications, refractory ascites, diuretic intolerant ascites, hepatorenal syndrome or spontaneous bacterial peritonitis. Child B and child C liver cirrhosis, yes, there are soft indications. There are many other factors which add up to that. MELD score 14 or more. And then there are serious complications like acute and chronic liver failure or hepatocellular carcinoma, commonly liver cancer. Then there are non-cirrhotic indications for liver transplant. The first thing is acute liver failure. Acute liver failure is where the liver fails in a patient who does not have any history of liver disease. A patient suddenly presents with fever, diagnosed as dengue fever, and within few days develops jaundice, and within few days of developing jaundice develops altered sensorium and goes into hepatic encephalopathy. So that is acute liver failure. Definition is jaundice followed by hepatic encephalopathy within 26 weeks of time. And common causes are drug overdose, commonly paracetamol poisoning, dengue fever, Retol poisoning, hepatitis A, E, hepatitis B, C, and then there are other causes. Not all patients need transplantation in acute liver failure. So how do we decide that this patient would require transplant, this patient won't require transplant? A lot of things depend on the cause of liver failure. So patients who have acute liver failure because of paracetamol poisoning, acute hepatitis A, shock liver or pregnancy related liver disease have a transplant free survival more than 50%. And these patients probably may be managed conservatively without needing a transplant. Whereas in other causes, mainly hepatitis B and hepatitis C related liver failure, these patients most of the time they need a liver transplant to survive. There are some criteria, commonly known criteria are King's College criteria, and then there are other criteria also which are available online to judge. But King's College criteria are commonly used to decide whether the patient should be advised transplant or not. But still clinical judgment is the best tool to decide, as always in most illnesses. But there is a short window for transplant, and in early period of acute liver failure, cerebral edema is the major cause of mortality, and in the later period, it is the sepsis which takes the toll in the acute liver failure patients. Second non-cirrhotic indication is hepatocellular carcinoma, liver cancer, most common primary malignant tumor of the liver, commonly seen in cirrhotic livers, and the treatment of choice is resection, but it can be seen in non-cirrhotic livers also, and the transplantation may be required depending on the location of the tumor. Sometimes the tumors are so located or so large in size that they may not be resectable, and then these patients would require transplantation. There are various criteria to judge whether this patient should be advised transplant or not, and early transplant can be life-saving. વધારે અગત્યનો પ્રશ્ન છે when not to operate. We know now that okay, such patient should be operated, but sometimes we may have patients, we may have donor, we may have the indication for transplant, but still we'll decide that this patient should not be transplanted. And the first contraindication for transplant is active, uncontrolled, refractory, extrahepatic cancer, malignancy or infection. Severe cardiopulmonary comorbidities, renal dysfunction, active untreated psychiatric illness, alcohol or any other substance abuse is generally a contraindication for liver transplantation. Second question that we'll address today is how to prepare. Once we have decided, okay, this patient needs a liver transplant, then what needs to be done? So the first thing that comes to mind is whether to advise cadaveric transplantation or living donor transplantation. And the patient would ask upfront કે ઓકે સાહેબ ખબર છે આપણને બે રીતે ટ્રાન્સપ્લાન્ટ થાય છે તમે સમજાયું પણ આપણે કઈ રીતના કરાવવું જોઈએ. તો for that there are some advantages, there are some pros and cons of both modalities. Most importantly, the waiting list period. In cadaver transplantation there is a waiting period of 3 to 6 months. In living donor transplantation there is no waiting period. Also, cadaveric transplantation may be preferred for patients who are obese, who are more than 100 kg of weight, because they need a larger liver, and in living donor transplantation you get a smaller liver compared to cadaveric liver transplantation. So in nutshell, living donor liver transplant should be advised when the patient needs an early transplant and the patient cannot wait for a cadaveric liver transplant. Common indications, complications of liver cirrhosis have happened. Patient who has presented with acute and chronic liver failure, patient who has acute liver failure, as we discussed earlier, they cannot wait for a cadaveric liver. Patients with liver cancers, hepatocellular carcinoma, and any patient who has a donor in the family should be advised to go for a living donor transplant. Rest all the patients and the patients who do not have donors in the family, the best option is cadaveric liver transplant. Coming to cadaveric liver transplant, we have an umbrella organization in Gujarat state which is called SOTO, which carries over the registration of patients for cadaveric liver transplant. So the patients need to be registered in SOTO, and the procedure is very simple. There are some blood investigations which need to be done. Then there is imaging, CT abdomen or liver Doppler, X-ray, ECG, 2D echo, DSC, PFT for cardiopulmonary fitness, ancillary specialties, see the patient, and then you need some documents, and the patient is listed for cadaveric liver transplantation. The whole process takes around 2 to 3 days, and after that one can be registered for cadaveric transplant. After listing, what next? What needs to be done? So the patient needs to be at regular follow-up. It can be done at a local hospital in Bhavnagar also. There are some investigations which need to be repeated at regular interval, and they are to be updated on SOTO website. And the patient has to wait for call. Once the patient gets a call, he or she has to reach the hospital on where he has been registered as soon as the organ is available. Living donor liver transplant. First thing is donor selection. That's another question that comes commonly from the family. કે સાહેબ કોણ આપી શકે કુટુંબમાંથી? So one thing is there is some age criteria, 18 to 15 years of age. Blood group compatible. When we talk about blood group compatible, we need only ABO compatibility. RH compatibility is not required, and that's the only compatibility that we need. No HLA matching or no LCM matching or nothing else is required. And, blood group, again, as we know that O group is universal donor and AB group is universal recipient. The donor should be preferably related to the family. Blood investigations need to be done, imaging, plain CT, triphasic CT. We see how much fat is there in the donor liver, and then we accept the donor for the surgery. MRCP for biliary mapping, then other investigations for cardiopulmonary fitness for the surgery. So these are the investigations that we do in donor for living donor transplant. These are some examples of the images that we do. There are two terms that are important, GRWR, which is graft recipient weight ratio. That's the ratio of the graft weight and the recipient weight. And the remnant, that is the liver, part of the liver which stays with the donor after the surgery. So these things should be enough for the recipient and the donor respectively. So after this thing has been done, what next? After this, what? So documentation, and then there is authorization committee approval, and after that we can go ahead with the transplant. So then after transplant, another thing is post-transplant care and long-term outcome of the patient. So early post-transplant care, when the patient is in the hospital, is in the ICU and then to the room, patient is generally extubated on post-operative day 1. Immunosuppression is started early to prevent rejection. Immunosuppression is given in all organ transplants, irrespective of the organ that we are transplanting, and is generally a combination of 3 drugs. Patient is kept in ICU for 5 to 7 days. Mobilized and feeds are started generally on second post-operative day. These are also the questions that commonly a patient's family asks. કે સાહેબ ટ્રાન્સપ્લાન્ટ પછી કેટલા દિવસ આઈસીયુમાં રહેવાનું, કેટલા દિવસ હોસ્પિટલમાં રહેવાનું, અને ખાવા પીવાનું ક્યારે ચાલુ થશે, ચાલવાનું ક્યારે ચાલુ થશે. So needs to be in the hospital for 2 to 3 weeks. Surgical stitches are removed by 2 to 3 weeks. Long-term care, all these patients remain on lifelong immunosuppression as of now. There are some studies going on that how can we stop immunosuppression, but still all the patients are supposed to be on lifelong immunosuppression. At the end of 1 year, most patients are on 1 tablet twice a day. Commonly used medicine is tacrolimus. Blood investigations are done regularly at 3 to 6 months interval, and these investigations are mainly complete blood counts, liver function test, kidney function test, and level of tacrolimus in the blood. No isolation is required after discharge. Precautions that need to be taken are plainly clean water, clean food, and stay away from unwell people. Recipients and donors both can join work, have children, go for gyms, go for movies, go to gym, pursue any sports activity. Donors are not on any medication long term, and they can live a normal life. The outcomes have improved significantly in last few years of liver transplantation. So previously the outcomes were not so good, but now we are able to give consistent results in 90 to 95% of the patients, and the risk to life in recipient is 5 to 10%. The time for the liver to regenerate, as we discussed in the first slide, that liver regenerates. So here also the liver regenerates both in donor and the recipient, and generally the time taken is 1.5 to 2 months. The operative risk in recipient is 5 to 10%, and the risk for the donor is 0.2 to 0.5%, which is very nominal risk. The donor hospital stay is approximately 5 to 8 days. The liver stays lifelong with the patient and stays healthy lifelong if it is taken good care of after transplant. The quality of life for the recipient and the donor both are excellent. There is no shelf life or expiry date for a transplanted liver. So coming to the first slide that we had seen, both these patients underwent transplant. And this is on the left side, that girl is sitting with me 2 months after transplant. She was in acute liver failure because of autoimmune liver disease, and her father donated a part of the liver. So she did well. Now it is 2 years after transplant. She is going to school, taking part in sports activities, recently participated in Garba, Navratri, and taking her medicine regularly. She is doing well. And the other patient, 70-year-old, that video is 10th day post-operatively when he is in the room and doing exercises. So then there is a cohort, there is a subset of patients where early transplant is needed because of the indications that we discussed previously, but there is no eligible donor in the family. So then comes in picture innovations in liver transplant. So innovations in liver transplant, first thing is dual lobe liver transplant. This is the, here we take livers from 2 donors. For example, right lobe from one donor and left lobe or left lateral section from the other donor, and we implant in one recipient. So this is generally indicated where the recipients are quite heavy, their weight is quite high, more than 100, and they cannot wait for a cadaveric transplant. So in such case, we did one dual lobe transplant, which was the first in Gujarat. And here we took right lobe from one donor and left lateral lobe from the second donor. This is the operative picture. Second is swap transplant or ABO mismatch transplant, where we take liver from one donor of the one family and implant in the recipient of the other family, and the donor of that other family gives liver to the recipient of the first family. So this is called swap, adla badli, and both these transplants happen together. They have to be done simultaneously. And the third option is ABO incompatible transplant, which has come in a big way in kidney transplants, also in liver transplant. Now it is catching up, wherein we suppress the B cell mediated immunity by some medications and plasmapheresis, and then we do the transplant. So it has also found to have good outcomes. To conclude, patients with liver cirrhosis may live for a long time without needing a transplant. However, there are definitive indications for liver transplant, and liver transplant is at present the only curative option for liver cirrhosis. Liver transplant is a curative option for non-cirrhotic conditions also, like acute liver failure, liver cancers in non-cirrhotic patients. Transplant gives a normal survival and a better quality of life, and perioperative optimization is key to provide good outcomes to the patient. Thank you.
Thank you so much, Divakarji, for a nice, compact presentation for this curious topic to all of us. Any questions?
Yes, sir.
Yeah.
Sir, as you talk about pediatric liver transplantation, mostly from government setup we do have this kind of patients, but main is the cost constraint.
Yeah.
So my concern is whether KD is having this school health program incorporation in licensing with government or not, then how it can be minimized as far as cost is concerned.
So KD hospital as such, we for pediatric patients, we generally give concessions on the cost. Second is we have license with many charity organizations and crowdfunding platforms through which we try to get money, and for pediatric patients we get good amount of funds when they need transplants or any major surgery. In fact, we have, not in KD, but when I was in Mumbai, Kotlabin, we did a transplant where the whole of the funds were raised on crowdfunding and the patient surgery was free. So for pediatric patients, we get good amount of funds, and then the government provides help from the CM Relief Fund, that is approximately 4 to 4.5 lakh rupees. This child that we operated, 8-year-old child, so there she got 4.5 lakh rupees from the government also, from CM Relief Funds. So that way we try to help the pediatric patients in that way.
Okay.
We can transplant the liver.
So I would need more information. You said it is liver cancer?
Yes.
Is it hepatocellular carcinoma?
Hepatocellular.
And then what you said, there are two
There are no metastases.
No metastasis.
Yes.
So then, see, the outcome with transplant in such patients depends on, one, the size of the tumor, the number of the lesions, whether there is any portal vein invasion or not, whether there is any hepatic artery invasion or not, whether there is any extrahepatic disease or not. So on the basis of that, we decide whether this patient would benefit. If it is a non-cirrhotic liver, if the tumor is small in size, we can easily go for resection and other modalities like TACE or RFA or ablations of any other type. But if it is cirrhotic liver, then we have to see all these criteria. The AFP level also is supposed to be seen, and then we can say whether the transplant will give good outcomes or not. There are different criteria, as I had discussed in one slide, one of which is Milan criteria, which gives these guidelines how to select the patients. And if our patient is within the Milan criteria, then these patients have 70 to 80% 5-year survival after transplant, which is better than any other modality.
So without transplant, he will not survive for 2.
Transplant provides the best survival modality for liver HCC in liver cirrhosis, but the first question that we need to address is whether the patient is transplantable or not. If the tumor has invaded portal vein or hepatic artery within the liver.
He is non-cirrhotic but alcoholic.
Yeah, so that is okay. Then
we have to see. Liver is not that spoiled like.
So if it is non-cirrhotic, then there are other possibilities also. We can go for resection or other modalities also. But if resection is not possible.
Thank you very much. We are running short of time. Thank you very much, the audience. If anybody wants any further questions, they can ask during the lunchtime personally.
Please. I think, Dr. Divakar, you are not going to be free at lunch because there are a lot of questions waiting for you.
I request chairmen to facilitate our speaker, Dr. Divakar. I request Dr. Nilesh Parekh sir to facilitate our chairmans. Thank you. Thank you, Samir sir. Thank you, Rana sir.
Moving on from the liver to the brain. So the human brain is a wonderful organ. It works 24/7 from the time we are born to the time we die. But there are 2 exceptions. Any guesses? What are the 2 exceptions when the brain stops functioning? The 2 exceptions are, one, during exams. We have a lot of professors, so they know that the students on the other side, always during exams, they say that I forgot. I knew it very well yesterday, but today I have forgotten. And the second is when you really fall in love. Inviting the chairpersons for the next session, we have our senior neurologist from Bhavnagar, Dr. Atul Tipnis sir. He's a gold medalist from MS University, Baroda, and is practicing in Bhavnagar since the past 38 years, and he has many publications to his credit. The next chairperson for this session is none other than Dr. Rajendra Kabaria. He is working as a consultant neurosurgeon in Bhavnagar since 25 years. And he is working his voluntary services at the Government Medical College Bhavnagar for the past 22 years. I can proudly say that he is the flag bearer of organ donation in Bhavnagar, and he has received numerous awards and accolades for the same. He is the recipient of the Dharti Ratna Award, the Kaushalya Vandana Award, and many more to his credit. So over to you, Chairman Sirs. We would like you to introduce the speaker to the audience.
Good morning, everybody. Video EEG telemetry or monitoring is a very important tool in the diagnosis and management of epilepsy. Right from the differentiation between an organic and a psychogenic seizure or a syncopal episode to classifying the seizure, delineating the focus of epilepsy and a prerequisite for epilepsy surgery. Today we have to talk about video telemetry. Dr. Abhishek Gohil, he is a neurologist and epileptologist from KD Hospital, Ahmedabad. He did his MBBS and MD from Ahmedabad, DM Neurology from the famous NIMHANS, and fellowship in epilepsy from Amrita Institute of Medical Science. He topped the national exam for securing admissions in NIMHANS. He secured DM neurology seat at Trivandrum, topped the theory paper of AIMS DM neurology. He is working at KD Hospital as an adult and pediatric epileptologist and has he has authored a chapter in a book, 3 papers in international journals and 6 papers in national journals. Dr. Abhishek Goyal, if I recollect, you are from somewhere near Bhavnagar, basically. You are from Mawa. So we are all the more proud that Dr. Abhishek Goyal is our doctor. Dr. Goyal, please.
I'm Dr. Abhishek Gohel. I work as a neurologist and epileptologist at KD Hospital, Ahmedabad. So today I will be discussing on utility of this excellent tool that we have, video EEG. So this is a sneak peek. We start with indications, then we go to case examples. I'll be showing some few interesting videos, and then I'll be discussing how we can use it as a pre-surgical workup, and then we will conclude. So there are 4 indications of video EEGs. First is differentiating between seizures and non-epileptic events. Okay. Second is classification of seizure types and seizure syndromes, epilepsy syndromes. Next is we have to quantify the seizure burden in a patient. And fourth is electroclinical characterization. So what is all these things that we will discuss subsequently. So what is so peculiar about paroxysmal events? In medical field, we have 2 types of symptoms. First is paroxysmal, second is non-paroxysmal. Say for example, a patient is having fever or the patient is having a stroke. They had fever and they had stroke and then they are coming to us. So when we examine the patient, they might be having a stroke and you can examine the stroke in front of you. We can do the reflexes, we can do a motor power examination, everything. But with paroxysmal events, it has, by definition, they have come and they have gone. And so patient comes walking to us in OPD and we have nothing to examine at that point of time. So what has happened in the past has happened in the past. So this is the problem with paroxysmal events, and it can be anything. It can be syncope, it can be seizure, it can be n number of things. And video EEG is a tool that encapsulates that event in time for us to examine in the future. So by that definition, video EEG is examination of seizures. So how do we approach such problems? So there are basically 2 types of problems. First is direct problem, second is indirect problem. Direct problem is, it has rained, okay. You see the rain in front of you and the street becomes wet because of the rain. It is direct, it is very easy, everyone can solve it. What is inverse problem? There lies the money, okay. So inverse problem is, it has rained, nobody has seen the rain and the street is wet. So what we have right now in front of us is a wet street, and now we have to go back in time. We have to go back in time and formulate hypothesis why the street is wet. It might have rained, it might have somebody might have just thrown the water from their bucket. Okay. So when such a patient comes to us, we have perception. Reality has already happened in the past. What we have right now is perception. So when they come to OPD to us, we have subjective recollection from the patient. So what the patient is saying, what happened to the patient, maybe a tongue bite, maybe something that, and then we have witness recollection. That is objective history. And that is the perception, that is the shadow. And based on this shadow, we have to estimate what is this shadow from, where is this perception coming from. So whether it is this or whether it is this, we do not know. So these are our differential diagnosis. This is our hypothesis. Video EEG is a tool that shines light upon brain and differentiates different kinds of events. Maybe epileptic, non-epileptic, it can be syncopal event, cardiac event, something. Or it can be anything of the entire plethora of events. Say for example panic attacks, it can be transient ischemic attack, it can be dystonic attack, acute dystonia, hypnic jerks, whatever. So let us, without any further ado, we go into the interesting case scenarios. So this is a 29-year-old guy. He has multiple such daily nocturnal events. He has consulted multiple specialties, topmost cardiologists, psychiatrists, neurologists, sleep specialists, everything. And multiple EEGs were done and they were normal. He was considered to have some psychiatric illness or something, and he was tried on multiple medications. Nothing works, but he is on antipsychotics. So whether this is a seizure or not, this is there lies money, right? So I request all of you to take out your mobile phones and scan this QR code right now. Let us just vote, okay? Sir? Okay. Fine, we can just raise the hands then. Okay. Who considers these events as epileptic event? Okay. So I will just assume that others consider it as non-epileptic. Okay. Next is this lady. She is a young lady, multiple stress. And 2 or 3 times in a week she has these events. She has just this kind of jerks with pouting. She is unresponsive during the event. She does not respond to any medication, not to any psychiatry medication, not to any anti-seizure medications. She remains unresponsive for a prolonged period of time. So she keeps doing this for 1.5 to 2 minutes. Okay. Now, whether it was a non-epileptic event or epileptic, raise hands for epileptic event. Okay, significant number, right? Okay. Next is this young lady. She is a tax consultant. She is a CA. Daily nocturnal, she has these events where she wakes up and she just tosses herself to and fro like this in the bed. On multiple antipsychotic medication, anti-seizure medications, nothing. And EEGs were normal. EEGs are normal in all 3 of them. Okay. And then she becomes normal and then, okay. So again, I think the house is 50-50% divided, right? Epileptic versus non-epileptic. So now we have, this is even on looking at the video, it is very confusing, right? So whether epileptic or non-epileptic. This guy, first guy, is a cingulate epilepsy. It is a seizure. Second lady, it is, she was a psychiatric patient, and then she improved by cognitive behavioral therapy, non-epileptic event. And third, this lady is an insular epilepsy. She responded to surgery. She is seizure free for 4 years after insular resection. So it is that difficult to interpret whether it is epileptic or non-epileptic, even based on the video EG, based on the video. So how difficult it will be to diagnose such things on historical basis when the patient comes walking to you. Next we have this lady, fourth case. She's a 45-year-old lady, and she has this infrequent just falls, just this kind of falls. And she becomes unconscious after this falls. And then there is some posturing. And then she slowly comes back to normalcy. So we did video EG for this falls, what is going on actually. So I'll just so this is the corresponding EEG. As we can see, we have a clear-cut ictal activity over the right temporal region. This is the right temporal region. Blue is right, black is left. So right temporal region, we have this nice activity, right? So it is an ictal activity. And then it becomes faster over here, over the same region. And then there is a fall. This is the artifact of fall. That is where she falls down. And after the fall, there is slowing, a diffuse slowing, cerebral slowing. And then she becomes normal, she regains, and normal activity resumes. So again, what has happened? Even after looking at video, even after looking at the EEG, nothing makes sense. So what is happening over here, I'll just look at the ECG. It is 60. So this one is 1 second over here. So 60 rate at this point of time on ECG. And we have bradycardia, and then asystole. We have prolonged asystole, that is when we have syncope, and then that is why, because of cerebral hypoperfusion, she falls down. And then we have a lot of slowing over the EEG. What has actually happened is, she was already in seizure when the video started. She was not normal, she was in seizure. But when she is in seizure, that is not detected. Only when she falls and there is posturing, when there is asystole, a bradycardia so severe, only then and then only it is detected as diagnosed as some event. Whether seizure or not, we don't know. Okay. So what has actually happened now? The heart is beating normally. The brain starts seizing. We have ictal dysautonomia. A bradycardia so severe, it causes the heart to stop beating. And then there is cerebral anoxia, which inhibits the brain, which inhibits seizure. And then she regains. So this is an entire self-inhibitory cycle over here. And she responded to epilepsy surgery. She is better. No seizures, no falls after that. On the other hand, we have this young lady. There is restlessness, palpitation. She came with occasional drug refractory seizures. There is this aura of restlessness, palpitation. And then there is posturing, dystonic posturing. She looks towards the right and everything. And then she keeps on doing all these things for next 2 to 3 minutes. So what has happened over here is, the heart is beating normal this time. And the heart is beating normal, and then we have Torsades de points. That is a ventricular tachycardia that causes cerebral anoxia, which look like seizures. They are not seizures. If they are not seizures, they will not respond to anti-seizure medications. As simple as that. Okay. If there is no fever, paracetamol will not act on it, right? So on one hand, on the other hand, we have heart seizing, which causes brain seizures, which look like seizure, but they will not respond to anti-seizure medications. So we have this asystole spectrum. We have ictal asystole as a autonomic manifestation of seizure. It might be the only manifestation. On the other hand, we have cardiac asystole, which might look like seizure, and video EEG helps us differentiate between these two events. So when patients come to us, right, seizure versus syncope, video EEG is required at that point. Next is quantification of seizure burden. This lady, she had previously uncontrolled seizures, daily multiple events, by multiple I mean 40-50 events in a day. And after medications, she says that, okay doctor, I am normal now, normal right now, I do not have any seizure at present. And so we did video EEG now. And what happened? Just look at her, this movement, this small movement, I'll just show. Look at her hand, this small movement, that is a seizure. How do we know that? By corresponding EEG. So every 10 seconds, she has this one small jerk in the night. So she is not seizure free. Okay, she is not seizure free. And that is why it requires better titration of medication. Certainly do not reduce the medications. This helps us to quantify seizure burden in such cases. So that we avoid a titanic risk that you reduce the medication and then the patient might go into some sort of status epilepticus. This is another lady, 42-year-old lady. She is a case of temporal lobe epilepsy. On adequate medication, she continues to have seizures on medication. So it is temporal lobe epilepsy, on medication, continues to have seizures. So we just did video EEG. They were unhappy with the doctor's treatment, okay. So she has these movements, side to side movement of the jaw, right upper limb posturing and everything. And in the same event, same recording, we got another event where there is some oral automatisms, as we can see over here, oral automatisms, and there will be posturing, as we can see, and then there is bimanual automatisms. So this is true seizure. So in the same patient, we have psychogenic seizure as well as true seizure. So what has happened is, she has looked at her own video at home and she just wants people or the family to believe that she continues to have seizures. So she tries to mimic her own epilepsy at home. So, and how do we know it is seizure? We have clear-cut theta activity over here. So, this video EEG helps us in quantification of true seizure burden. On one hand, we have patients who tell us, everything is fine doctor. Why are you reducing the medications? Why are you not reducing the medications? Please, please. So, it does not make sense, right? Because when we do video EEG, she might have a lot of seizures which have been just undiagnosed by her. Ignorance is bliss, but is it really? Not in this case. So this exemplifies false negative. Next we have patients who are adequately really on control on real seizures, and they still complain that medications have stopped working, please do something about it. And when we do the video EEG, we have plenty of non-epileptic events which require behavioral therapy. Next, video EEG helps us in diagnosing absence seizures. This is a hyperventilation maneuver. She stops doing whatever she's doing. This is absence seizure. And we have 3 Hz spike and wave activity over here. So it helps us in classifying. Next, we have eye closure discharges. The patient closes the eye and the patient will have a lot of ictal activity just on eye closure. This is another syndrome known as chest out syndrome. I will show you. So these are the eye closure discharges. Okay, he closes the eye over here, he opens it here, and we have discharges. And as a last case of today, we have it as a pre-surgical workup. So what happens is, the patient is having a lesion in the brain, and we have concordant activity, and then we quantify the epileptogenic zone, and then we remove it, and the patient becomes seizure free. So I'll just skip these slides. So whether drug reduction for video EEG is worth the risk, I would say yes, because the patient is drug refractory, right? That is why the patient comes to us. The patient is already seizing at home. At home, we do not have ICU or any medical backup. And at hospital, we have good adequate backup. So, and this maneuver helps the patient give a chance at seizure freedom. So risk-benefit ratio is favoring drug reduction for video EEG. This is another boy. He had multiple axial tonic seizures. I'll show. Left upper limb posturing and everything. He wakes up in the night. Just this posturing. Daily events. So what we do is, we do dedicated MRI. So not epilepsy protocol. This is harness protocol. We go next level. Without any gaps, this is volumetric T1 and flare acquisition in designated centers. We set the protocol, and we get images in all 3 dimensions. We process it on our MATLAB algorithm, and then we have derivative images like this. And MRI was normal in this case, but I do not think so. There is some gray white matter.
Abhishek, we are lacking time.
Sir?
We are short of time.
Okay, sir. 2 minutes. And then PET shows hypoperfusion hypometabolism at that point. We do post-processing on this PET scans, that is PASCOM, and then we do resection. The neurosurgeon does resection, and the patient is seizure free. So at KD hospital, we have completed 6 such surgeries in last 10 months, including 2 babies and everything, and all the patients are seizure free. So take home points is, video EEG is examination of seizures. Treatment cannot be better than diagnosis. So diagnosis is the first. Better the devil you know than the devil you don't. And if it does not harm, that is, the patient is already seizing at home, and if it can potentially benefit the patient, that is, it opens up new options for better management, better to capture it. So this goes in line with the precautionary principle. Thank you. I end my presentation.
Thank you, Abhishek, for nice presentation. We are lacking of time. Only one question is allowed from our audience.
Sir.
Any question?
Yes. What are the prerequisites of video EEG, like conventional EEG? And second thing, we know this tool is there as a diagnostic modality, but still it is not that much awareness has been created or people are using, especially the pediatrician.
Yes.
So why?
So video EEG is just not EEG. It is examination of the semiology of how the symptoms manifest themselves. So it requires a lot of hours of timing from a physician's point of view. So say for example, if you do 3-day video EEG, that is 72 hours, 72 hours of recording has to be analyzed very dedicatedly. That is why we are a team of 2 epileptologists, neurologists at KD hospital, who do dedicated such recording on an alternate day basis. Next is when to do video EEG. When the diagnosis is in question for any paroxysmal event, better to get it done, because nobody drives the bus blindfolded, right? We need to know what we are doing. So it helps us in quantification of that.
Thank you.
For video EEG. Okay. So at KD hospital, for 1 day, I mean if it is daily events, so we require only 1 day, right? So 24 hours, it is around 12,000 rupees. That includes everything. And for 3 days, so 6,000 next day, 6,000 next day. So it is almost 24,000 video EEG for 3 days. So for all the pre-surgical patients, we get it done in 24,000. એક રેકોર્ડિંગ જોતા, it depends upon number of events. મેં 150-200 ઇવેન્ટ સુધીના રિપોર્ટિંગ કર્યા છે, એમાં તો મારા 4-5 દિવસ જતા રહ્યા હતા, પણ રૂટીનલી અમે કરતા હોય તો 4-5 કલાક તો જતા રહે જે નોર્મલ પેશન્ટ હોય ને.
If there is no event during the 72 hours which you do, then what do you do?
We prolong. We prolong.
And then he'll have to pay more.
No, I mean all those things have been discussed with the patient, and then we reduce the.
And last point, have you come across seizures where the semiology is suggestive of a seizure, but you don't find any electrical activity?
So many. If the focus is deep-seated in the midbrain, in the middle of the brain, that is mesial surfaces, then EEG will be, surface EEG will be completely normal.
Thank you.
And just a minute, I will take just 5 seconds more. I have started my monthly OPDs at Bhavnagar and Moua dedicated for drug refractory epilepsy patient. On second Saturday, I go to Moua. On second Sunday of the month, I come to Bhavnagar Bajrang Das Bapa. Thank you so much.
Thank you.
We would request the chairpersons to felicitate the speaker. We would now like to request Dr. Panjwani sir to felicitate the chairpersons as well. We are living in interesting times, I guess. The innovation is limitless. It's a fantastic time to be operating right now, and I think Dr. Mahesh would agree to it. The landscape is going to change quite a lot, and the change has already begun. The future of medicine is definitely AI. So taking us further is our next speaker.
Moving on to next section, I would like to invite Dr. M.V. Dhanak sir and Dr. Bharatbhai Trivedi to take the chair, sir. Dr. Dhanak sir is a senior most anesthesiologist in Bhavnagar. Dr. Bharatbhai Trivedi is one of the senior most general surgeon who has started his career as MBBS with a gold medal, and after getting laparoscopic training in Singapore in 1993, he was one of the pioneer in laparoscopic surgery in Bhavnagar, Gujarat. He has served in MP Shah Medical College also and in Surrey Hospital. And at present, he is working with the Beams Hospital. So, sir, chairperson, sir, now the session is with you.
Good morning, everybody. It is my pleasure to chair the person, to be the chairperson in this conference. Now our next session starts with Dr. Mahesh Patel, who is senior oncosurgeon, and he is associated with Zydus Cancer Center as full-time consultant GI and thoracic oncosurgery. He has vast experience in dealing with complex GI and thoracic oncosurgical cases. He does it laparoscopically and robotically, which is a newer concept in surgery. He also carries vast experience in interventional endoscopy, resulting in better clinical outcomes of GI and thoracic oncosurgical cases. His special area of interest are complex surgeries. So I invite Dr. Mahesh D. Patel, senior oncosurgeon. Please come on the stage and deliver your lecture. Thank you.
Thank you very much for the warm welcome, and it's a pleasure to be here. If we can start the video. So I'll just show you a brief overview of how the robotic system is. So this is the main machine of the robot. You can see the 4 arms. So this is the actual robotic arm. It can be used 14 times. That is the way it has been preformed. I don't know if you can focus on this. You can see the movements of the instrument. They move like my hand. So this is one arm, and similarly we have 3 other arms. We also have a camera which can actually magnify everything 10 times. If I have to just give a brief idea about how robotic has already penetrated, 15% of all the surgeries done in America, all the surgeries are robotic now. So there are around 7,500 installations in the US. And India, we have already 120 robotic systems. If I have to talk about last year, 21,000 surgeries in India were done robotically. Whether it's real or hype, I don't think the debate is any more valid for the fact that the transition has already been taken. It's just a matter of time when the cost of this instrument decreases, everyone will practically be doing robotically. So these are the ways, you can see that this is the way I move my hand and the instrument moves accordingly. So to impress upon you all why robotic is real, I'd like to show certain videos of surgeries which even if we do it open or laparoscopy, it's going to be extremely difficult. So the first video I'd like to show is a robotic caudate lobe HCC excision. Now, as we all know, caudate lobe is segment 1 of the liver. Extremely difficult to do because it has been, it wraps the IVC around. And this caudate lobe HCC was one of the largest done in the world. So as you can see the anatomy, got a pointer? So the caudate lobe is supplied by the portal veins, the hepatic artery, and it drains into the IVC. So if you can see, this is the HCC. He was a 75-year-old gentleman, and it was a 9-centimeter mass. In robotics, we use only monopolar and bipolar, nothing fancy. So here I'm actually cutting the Aranches ligament, and I'm going up to the left hepatic vein. That is the first step. This is the tumor. Here I'm cutting the lesser omentum. This is the pancreas. Here I'm lifting the hepatocellular carcinoma, and this is the IVC. I'm making a precise cut on the peritoneum over the IVC. The air passes in, and I'm getting that plane from where I'll tackle all these veins which go into the IVC. So they can be up to 3 to 5 veins which drain the caudate lobe into the IVC. This is the left lateral ligament of the liver. This is the IVC. These are the veins which drain into the IVC. I can actually clip them, cut them. I can use energy source. I can use a vessel sealer. So there are a lot of options which I have. Once I have tackled the smaller veins which drain into the IVC, these are the larger veins which drain into the IVC. So depending on the size of the tumor, the veins are going to enlarge in size. So most of the surgeries when we do, half the battle is won because of the planning. So you exactly would want to find out the number of veins which are draining into the IVC. Because even if I do a small mistake here and I have a bleed, there's a possibility that I may have to convert this case. So once I've tackled the veins which drain into the IVC, I'll be shifting my focus into the inflow system. Inflow system is from the left portal vein main and the left hepatic artery. So the arterial supply, I can very easily tackle with a vessel sealer. So the tricky part in a caudate lobe excision is the venous drainage and the supply from the left portal vein. So this is the planning which is required. You do every step according to the way you have planned. So now, I'm going to be tackling the veins which are from the left portal vein. So you can see this is the left portal vein, and individually I'll have to find out each branch which supplies the tumor. So this is one branch which goes into the tumor. I'm taking care of it. There is another branch. So once I've taken care of the inflow and the outflow, I can further do the dissection. Now if you can see that the caudate lobe has, one part of the caudate lobe is called as the caudate process. Now the caudate process formed the margin of this tumor. So I could just cut the caudate process and get a margin for this tumor. But there was one large draining vein into the IVC which I had to still tackle. And this was that vein. So when you have a large vein, I can use a robotic stapler. So you have to know which instrument has to be used where. And then the final part is I'm just taking care of the Aranches ligament. I reconnect it to the upper part near the left hepatic vein where I've already done the dissection, and the tumor is going to be out. So this is a surgery, even if I do it open, it's going to be extremely difficult for me. I can do a lot of surgeries open. I may be able to do a few of them laparoscopically, but I may not think of doing them by any other modality other than open most of the time. But because of robo, I'm actually able to do a lot of procedures which otherwise I wouldn't have thought that I can do it laparoscopically. So you can see that the tumor is out, you put it in a bag, and you remove it out through a small phenol-steel incision. I could send this patient home on postoperative day 2. He had no blood transfusion. There was very minimal blood loss. Now coming to the next case, tracheal dissections. These, even in an open setup, they are extremely difficult to do. So I'll be showing a couple of cases of tracheal dissection. Fortunately, I was the first to do the laparoscopic tracheal dissection in India, and I've been the first to do the robotic tracheal dissections in India. Because of COVID, we understood that there's another modality called as ECMO. So when we are doing a tracheal dissection, we have to put in a tube, and that hampers the suturing. Now with the ECMO machine in hand, I can actually get the blood oxygenated without the tube. So that makes my suturing very easy. So this is the ECMO machine. We put a cannula into the IJV, another one into the femoral vein. The oxygenation happens outside. I don't require a tube, so I can dissect the trachea easily. I can reconstruct it easily. So we start with dividing the inferior pulmonary ligament, mobilize the lung. This is the vagus nerve. And this is the trachea. This is the superior vena cava. These are the branches from the vagus which go to the trachea. So this was a case of acid ingestion because of which the patient had a stricture in the trachea. So I'm mobilizing the trachea from the esophagus. Because of acid ingestion, there are going to be adhesions. The inflammation has caused adhesions. But you can very precisely do this dissection. I'm even protecting the vagus. Now put in the bronchoscope so I can know exactly the site where the stricture is. I keep further doing the dissection. And this is pure monopolar bipolar. So I know that that is the site of stricture. I keep the vagus out of arm's length. I take a stay suture on the site of stricture that helps in the traction which I require. And then I'm cutting open the trachea. As you can see, there is no tube inside. Here I'm actually dissecting the upper end of the trachea from the esophagus below. Again, the devil lies in the details. So the battle is won when you can plan these surgeries well. So I'm removing the stricturous part of the trachea. You can mobilize up to 1.5 rings on either side because trachea has a segmental blood supply. Any further mobilization can result in necrosis, which is devastating. So I'm mobilizing the lower end, I'm mobilizing the upper end. I've already mobilized the inferior pulmonary ligament. And now I'm starting the suturing. Now, in the absence of a tube, the suturing becomes quite easy. So we use barb sutures. You can see these small barbs on the thing. They help in keeping the suture tight without actually having a knot. So all laparoscopic movements are counterintuitive and all robotic movements are intuitive. So if I move my hand up, the movement is up. If I move my hand down, the movement is down. But in laparoscopy, if I move my hand up, the instrument goes down. So this is one difference which makes learning the initial part of robotics quite easy, but mastering robotics takes a long time. So we're getting both the cut ends of the trachea together. Here we were able to extubate the patient on table, reverse the patient out of ECMO on table, and I could send the patient home within 5 days. Here we are expanding the lung. We have put in water. There's no leak. The specimen is retrieved in a bag. The lung is inflated. This is a similar case which I had done it for malignancy. It was an adenoid cystic carcinoma. Just repeating the same steps. This is the vagus nerve. This is the azygous vein. In this case, I cut the azygous vein so because the length of resection was a bit longer. This is the superior vena cava. Again, I just find out where the tumor is. I cut open the trachea, remove the segment which I want. And resuture it. You can play the next video. So similar steps, so I'll just skip to the next video. So these are certain colorectal cases which I'm going to show you. If you can see, this is a large nodal mass on the aorta. This doesn't make it inoperable. It is a CA sigmoid. This is the precision with which, this is at an accelerated pace. This is the inferior mesenteric artery. I'm dissecting it out. This is the aorta below. and I'm able to actually dissect out the entire nodal mass away from the aorta. So you can see the aorta down. That's the bifurcation of the aorta. So I'm just trying to impress upon, so this is a case of, again, a CS sigmoid who had undergone radiation by a cobalt machine 15 years back. So it's a dictum that if you've been radiated by a cobalt machine, everything is inoperable after that. The aorta, the vessels arising from the aorta, everything are absolutely stuck. And this is what we see after 10 years. The mass was badly stuck to the aorta as well as the left iliac vessel. But here you can precisely dissect them, dissect out each and every sigmoid vessel. So individual sigmoid vessels are identified. You can clip them. And this is again plain monopolar, bipolar. Nothing fancy about it. Again, the difficult part is knowing when to operate, when not to operate. You can see these are the new vascularizations because of maybe radiation, and this is the place where it was stuck to the iliac artery. The patient had undergone a previous hysterectomy for the C endometrium. You can see that was the round ligament. So that is used as a landmark, knowing that, the iliac artery is just round the corner. And there I can see the iliac artery. So you can see this is the iliac artery, the shining structure is the iliac artery. You have to be ready for a resection of the iliac artery also in case you think that you're not getting a margin. Now these are cases which are extremely difficult to do either by open or by laparoscopic methods. And robotic does have a huge advantage when it comes to this. So you can see I've made up the entire iliac artery. You can see the entire iliac artery. And this is the last video of an excentation. I think so because of lack of time, we can actually skip this. You can stop it. So thank you very much.
Thank you, Dr. Mahesh Bhatt, for taking us on a fantastic voyage.
Thank you, sir.
We can allow one question.
Any question from the crowd?
એ પહેલાં જે વિડીયો દેખાડ્યો હતો સર, સો ધીસ થિંગ આ કેવી રીતે ચાલે કે
yes sir,
it works on internet. So my movement on the console gets
Right.
transmitted to the machine.
machine, right,
અને મશીનના જે આર્મ છે they start moving according to my hand movement.
right, right.
એટલે આજની તારીખમાં 5G ના કારણે હું મારા ઘરે બેસીને ઝાયડસમાં ઓપરેટ કરીશ એક દિવસ.
Very good, excellent, excellent. Thank you sir.
Thank you.
Thank you.
એટલે અહીંયા ઝાયડસમાં કેન્સર માટે we are just taking 1 lakh extra compared to laparoscopy. એટલે અમે 1 લાખ એક્સ્ટ્રા લઈ છીએ રોબોટિક માટે સર. એટલે માની લ્યો લેપ્રોસ્કોપી માટે ઇસોફેગસ કરતા હોય તો 4 લાખમાં કરી, તો રોબોટિક માટે 5 લાખ થઈ છે. શું સર? સર પહેલા ચૂકવી દીધા છે 21 કરોડ. ના સર, હવે એટલે વી હેવ પરચેઝ ધ મશીન.
એટલે નહીતર તો લોગિન લગઆઉટના 80,000 લેતા પહેલા એવી ખબર છે.
સર એમાં ઘણા બધા મોડેલ છે પણ અમે આ લઈ લીધું છે,
હા,
ખરીદી લીધું.
એટલે સવારે લોગિન થાય ને સાંજે લોગ આઉટ થાય, 10 સર્જરી કરી નાખે એટલે 8,000 માં પતી જાય.
અમે નથી કરતા એવું.
હા,
વી
તો
લોગ
ઠીક.
આઉટ એવરી ટાઈમ વી ફિનિશ ધ કેસ.
હા તો ઠીક, એમ નહીતર સસ્તું પડે થોડું. એ ક્લિપનું શું કરવાનું પછી? ક્લિપ અંદર છે ઈ?
પણ સર
આ ક્લિપ મારી છે જે તમે આર્ટરીઝમાં?
ક્લિપુ સર એ તો આપણે નોર્મલ લેપ્રોસ્કોપીની ક્લિપુ છે.
અચ્છા એવું
એ
છે.
તો અંદર જ
ઓકે,
રહેશે.
ઓકે.
એ કાઢવાનું નથી.
I think we'll have further discussion during the lunch session.
Now, please, sir, stay on that. I request Chairperson, sir, to honor the speaker.
Dr. Mahesh, sir, you have to be loaded prior to the lunch so that you can answer all your queries.
I request Dr. Rajesh Bhai Balar to honor the chairperson, sir.
Thank you, Dr. Balar Sahib. For all the spouses out there, the makeup session is on. Make sure once you come back, your husbands recognize you. There are no wrong numbers dialed. We had an interesting session on GI surgery, moving on to GI endoscopy. So pun intended, it is said that it requires guts to do an endoscopy. And hence we have the next speaker who has a lot of guts and who knows a lot of people inside out. And honestly speaking, he's one of the reasons that I'm married to a gastroenterologist.
Okay. So for the next session, I'm inviting Dr. Kamlesh Bhavisi sir and Dr. Umesh Parmar sir to chair the session. Dr. Bhavisi is a very senior surgeon and he would like to introduce himself as lifetime student of art and science of surgery. Dr. Umesh Parmar is again a gastroenterologist and practicing in Durva Gastrocare, Bhavnagar.
We would request our chairpersons to introduce the speaker, please.
Hello. For me, it is a very great pleasure to introduce Dr. Nilay Mehta. I think there cannot be better than, more pleasant than the introducing your own student. Dr. Nilay Mehta was my student once upon a time. Now I am learning from him almost in 3-4 times in a year. He did his UG PG from BJ Medical College, then went to Bombay and did his DM and DNB in gastroenterology from Bombay. I have a long list of his honors and fellowship, but I don't think he needs that introduction. We'll straight away go ahead with his origin, which we are interested in. Thank you.
Thank you, sir, for your kind introduction. And I also thank you all for coming over here for GIMACOM. So basically, I know most of you are family physicians or general physicians and surgeons. This is mainly to introduce what has happened into the field of endoscopy. Endoscopy is not a new thing, it's an old thing. The first endoscopy concept came in 1800, where Philip Bozzini developed something like this, which was called an endoscope. So endoscope is basically to see inside, and that is progressed in 1961. Can you just stop this light? It's too much of light over here. So, so in 1961, it was Hershowitz which first time gave the concept of flexible endoscopy, and that is what we do now. And as you can see, we do lots and lots of therapies with an endoscope, and I'm sticking to the gastrointestinal endoscopy right now. Thank you very much. So let's discuss few cases. This is a 50-year-old female came to us with obstructive jaundice and vomiting, suggestive of gastric outflow obstruction. So basically it's an obstructive jaundice, and it needs therapy. We know that in obstructive jaundice, excuse me please, in obstructive jaundice what we do is we call as ERCP. So if you have stones, we cannulate, we put guide wires, we dilate, and then we take out the stones. If it is a cancer, we go in and put stents, as you can see over here. So these are the stones coming out. This is basically something called screw, which is dilating this stricture, and then we place plastic or metal stent as we, whatever is required. But here there are two problems. One is that normally ERCP is done from the ampulla. Ampulla is situated into the second part of duodenum, you know, but because there is an obstruction at D1, which we call gastric outward obstruction, we cannot do normal ERCP. And in that case, how to tackle this situation? This patient actually had C8 pancreas, so two problems. We have to do stenting into the bile duct, and we have to place a stent into the duodenum, and we cannot do it because we cannot go to the ampulla. So in that case, what you can do is you can puncture the first part of duodenum and put a stent between the duodenum, perforate the duodenum and put a stent into the bile duct. Or you can perforate the stomach, go into the liver and put a stent between the liver and the stomach. So that is what we call as endoscopy guided procedure. So that this is what we did. This is called endoscopic ultrasound guided hepatogastrostomy. So this is left lobe of liver. We puncture left of the liver, go into the IHBR. So this is the biliary tree, and then we dilate the tract. After passing a wire from the stomach into the liver, we place a stent, and this is the stent which is coming. So this is the stricture of C8 pancreas. This is the bile duct into the liver, and we are now placing a stent from the stomach. So this is not a normal tract. Normal is from the ampulla into the bile duct. This is from the stomach into the liver bile duct, not the normal common bile duct. And that is what is being done over here. And this is the stent which is coming out. This is a gastric wall. So you can see we have perforated the gastric wall and place a stent between the stomach and into the liver. So that is what is possible nowadays. And then there is a second problem, and that is duodenal obstruction. So normally we used to put so after putting that stent between the liver and stomach, you have to place a stent into the duodenal stricture. But that also has a problem because the stent can get blocked and the patient comes back again with vomiting, duodenal obstruction. So in that case, what surgeons used to do, that is called gastrojejunostomy. Nowadays we do it endoscopically. So this is a stricture into the duodenum, and then what we do is we place a stent between the stomach and the jejunum. So this is the jejunal loop. Our scope is into the stomach. We put water with methylene blue into the jejunum and then puncture. We have a special stent, so we can puncture from the stomach into the jejunum, and that stent is placed between the stomach and jejunum, and you can do what we call EUS guided gastrojejunostomy. This is the stent flange which is opening up into the jejunum, and this is the stomach side. Because the fluid had contained methylene blue, you can see that first the fluid was put in the jejunum, and now the fluid is coming into the stomach. So you are 100% sure that you have connected stomach and jejunum, and in fact you can see jejunum from the stomach through that stent. So both the things could be solved because of endoscopy. One is putting a stent from the stomach into the liver, and second putting a stent from the stomach into the jejunum. This is the second case, 50-year-old, again obstructive jaundice. CT scan has showed stricture in CHD, but otherwise no lymphadenopathy, nothing. So should we go ahead and do surgery? But the surgeons want a tissue diagnosis. So we did ERCP, brush cytology, but it was inconclusive. So what can you do? We need to see whether it's a benign stricture or whether it's a malignant stricture. And the treatment for both is different. So what we do is something called spyglass. So it's a scope which goes from the normal ERCP scope. So it's a scope into the scope, and that scope goes into the bile duct, and you can see the the right hepatic duct and the left hepatic duct over here. So you can literally go into the bile duct, and then you can go near the stricture, and now we will see the stricture in a moment. And we saw the stricture, and that was malignancy. So not only you can see the stricture, you can take the biopsy, and then this patient was operated. Sometimes you must have seen large stones in the bile duct. Venkat has done, Umesh has done ERCP, and then the stone is too big. So he cannot take out the big stone with normal ERCP. So what we do is, again we use that spyglass. We go into the bile duct, because now we can see that stone. We can put a laser probe, and as the urosurgeons use laser for laser lithotripsy, gastroenterologists can do laser lithotripsy for a large stone into the bile duct, or even in the cystic duct, what we call as a Merizis syndrome. So that is what is possible nowadays. This is a third case. Patient has acute severe necrotizing pancreatitis. After 5 weeks, 4 weeks, patient comes back with fever, pain and vomiting. CT scan has shown a large collection. As you doctors know that because patient had pancreatitis, severe necrotizing pancreatitis, now patient has a necrotic collection which is behind the stomach and which is infected, and that's why patient is having fever. So what is the treatment? Treatment is either surgery, but we know, surgeons know that surgery has 2-3 problems. This is an infected necrosis. First, surgery has more inflammation, more morbidity, and second, when you have infected necrosis, surgeons can't take stitch between the stomach and that collection, and then they put drain, and then that drain remains for 6 months, 8 months and something like that. So what do you do then? You have to do endoscopy, and this is how you do endoscopy. Again, it is an endoscopy guided procedure, and so this is stomach. We puncture, again we perforate the stomach, go into that collection. This collection has huge amount of necrosis, and we put a special stent which is called hot Axio stent, which has a cautery. We just puncture, stent opens up, and you can see now this is the stomach part, and you can see the pus is coming out from the collection. So once that pus is drained out, what you do is, because this stent is in the stomach, going out of the stomach into the retroperitoneum, you can now take out all the necrotic collection outside the stomach, put it in the stomach, keep on doing it, and you can take out entire necrosis which is outside stomach, and you can take care of that necrotic collection. And that is how we treat nowadays infected necrosis. And this is at the end of the procedure. You can see that almost all the necrosis is been taken care of. But many a times as a general practitioner, you will be seeing so many collections which are following acute pancreatitis. Not all collections need this treatment. Only those collections which have symptoms, so they have pain, they have fever, they have vomiting, they can't eat. Those are the collections which should be drained either endoscopically or surgically, otherwise you don't touch them. This is a fourth case, 30-year-old man has alcoholic cirrhosis presented with upper GI bleed. So what are the causes of upper GI bleed? They are the varices. Varices can be into the esophagus or varices can be into the stomach. If it is in the esophagus, traditionally you go to Venkat, you go to Umesh, they'll put a band. If you have varices into the stomach like this, you go and put glue. Glue is a substance which is in the liquid form, which when it comes in contact with the blood, it solidifies. And that's how it blocks the varix. But if the varix is too big, you cannot put glue with endoscopy, because you put a needle into the varix, it will bleed massively. So what we do, again we do something called endoscopic ultrasound guided therapy, where again from the stomach, we puncture, go into the vessel. Now it is not something outside, this is a vessel, big vessel into the wall of the stomach, and we put coil, what intervention radiologists put, and that coil will block the varix. This is another case where initially glue was put, but patient came with recurrence of varix, and you see what this is what I am saying. You put a needle and it bleeds massively. We kept on putting needle, we kept on putting glue, but patient kept on bleeding. So there again what you do is what I showed you. You do something called endoscopic ultrasound. You see that vessel and you puncture that vessel and put a coil. So endoscopic ultrasound is an ultrasound with endoscope by which you can see further beyond. So we are now going outside of the lumen, because now we can see everything what is happening outside the lumen. So endoscopy is not just endoluminal, but it is outside lumen. This is another case, 65-year-old man. Actually this patient was from Bhavnagar, had bleeding PR, mucus in stool for last 1 year. Colonoscopy had revealed a large tumor into the rectum and lower anal canal. So she went to surgeon said, okay, we can take it out, but you need permanent colostomy. Of course you need a permanent colostomy because the tumor is at the anal verge. But then patient came to us and we did something called endoscopic submucosal dissection. Normal polyps you can take out with simple polypectomy. This is a pedunculated polyp, so we are applying a loop and then we cut it and then it is being taken care of. But if you have a lesion, big lesion, you cannot do polypectomy. What you need to do is something called endoscopic submucosal dissection. So it's basically a surgery, what we do with surgical like knives, and we cut the entire tumor endoscopically, and this is what this patient had. You can see a large tumor into the rectum, and you can see that these are the piles. So it is going up to the anal canal. So if you want to do a surgery, you have to do a permanent colostomy, but endoscopically we can do submucosal dissection. So I am cutting like a surgeon. You could see the piles there, and then we are going beneath the tumor, between the muscle and the tumor, and we take care of the entire lesion. This procedure took me around 7 hours, probably say 8 hours, and then we could take out the entire tumor en bloc. So it was a circumferential tumor into the rectum, reaching up to the anal canal, but you can take it out with this endoscopy procedure, what we call as endoscopic. So this is the muscle, this is the tumor. You can see we have created a space. These are our knives. This is called IT knife, and this is the raw area after taking out the tumor. This is the tumor which we have taken out, and you can see it's a big tumor, and you can see the raw area, and this is the circumferential raw area, and this is the anal verge. So you could see, you could save a colectomy, and also the patient did not require any colostomy, permanent colostomy. This is another case where patient is a 38-year-old female. Patient came with dysphagia. Now dysphagia can be because of the stricture or a foreign body. This stricture could be benign stricture. A patient has taken corrosive, patient can get stricture, which is a benign stricture. A patient has a reflux disease, acid comes up, patient can get a reflux stricture, which is a benign stricture, or patient can get a malignant stricture. But even without stricture, patient can get dysphagia, and that is because of the muscle disorders. There are a variety of muscle disorders of esophagus where because of that the esophagus goes into spasm and patient gets dysphagia. But remember one thing, whenever a patient has dysphagia, it is never psychological. So don't say that you have a psychological dysphagia. Dysphagia is always organic. So this patient had long-standing dysphagia. Dysphagia was for liquids. So you have a dysphagia for liquids more than the solid, it is muscle disorder. If it is dysphagia more for solids than liquid, it is stricture. Stricture could be malignant, stricture could be benign. But so that is how we differentiate whether it is a muscle disorder or whether it's an organic stricture, and that is causing dysphagia. So this patient had achalasia cardia, where you have muscle in the esophagus not working properly, so they are not pushing, and the junction, GE junction pressure is very high. So all the food remains into the esophagus. So in treatment, what we do is we do muscle myotomy at the GE junction so that the food by gravity would start going down. So traditionally surgeons used to do it, now we do it endoscopically, where we deliberately puncture the esophagus into the middle part, create a tunnel between the muscle and the mucosa into the esophagus, 7-8 centimeter into the esophagus at the GE junction, across the GE junction into the stomach, and then we cut the muscle of the lower esophagus, GE junction and upper stomach, and that will take care of the achalasia cardia problem. And this is how we do it. This is esophagus. We puncture, as you can see over here. Then we go into the submucosal space. This is the loose areolar tissue of the submucosal space. There is a muscle over here. Mucosa is over here. We create a long tunnel into the submucosal space. And once we reach the stomach, once we cross the GE junction, we start cutting the muscle, as you can see over here. Entire muscle is cut 6-7 centimeter into the esophagus, GE junction muscle, and also 2 centimeter in the stomach, as you can see over here. This is the cut margin of the stomach. And, oh, sorry. Yeah, and then once we cut, we close that incision. So this is entire myotomy. You can see these are the cut margins. This is the adventitia, and once the muscle is cut, you clip, this is the incision which we have made, you close that incision with endoscopy. So you perforate an organ, go out of the organ, and you do therapy, and then come back and then stitch the perforation, and that is what we do nowadays. And it's an excellent method to treat achalasia with an efficacy rate of around 98%. Because of that, nowadays we can do a lot of therapy. If you have a tumor, as you can see at the GE junction, we can do it, take it out endoscopically by this method. Many a times patient has something called Jenker's diverticulum, where you have a diverticulum in the throat. So we then puncture the mouth and then do myotomy of that muscle, and we can do therapies over there. So because of this therapy, nowadays again we do perforation, go out, do therapy, and take care of the disease. So this is what the tumor is, entire tumor, and this is the tumor which is outside the esophagus, but we are taking out it from the esophagus, and this is how we cut the muscle and then stitch at the Jenker's diverticulum. Patient has GERD, patient is on PPI for a long time, and patient cannot stop PPI. Then what do? Then we ask the patient to go to a surgeon and do anti-reflux surgery, which is a standard therapy. But this patient was a young female, she didn't want surgery. So what you can do is, what surgeons do is, with surgery, they increase the pressure at GE junction. We can do it endoscopically because we have now full thickness clips available, full thickness. This is a plicator device. So you see a gap at GE junction, the plication opens, screw comes up, we take the GE junction into our instrument and apply that plication, one plicator and then the second plicator. You can see this is the scope, this is the GE junction, first plicator was applied, now the second plicator is applied, and that will increase the pressure at GE junction. As you can see, this is like a rep what surgeons do in anti-reflux. So same rep, now you can do it endoscopically. Of course, endoscopy is not for everyone. Still the standard of therapy for GERD is medicine first, and then if it is a large hiatus hernia, surgery. But if it is not a large hiatus hernia, then surgery is also possible. This is probably my last case, young female, obese patient, wants to go for surgery, and this is a common scenario nowadays, we get it. These patients are not suitable for surgery. Obviously, patient would not go for surgery if patient wants to get married. And there, the surgery comes into picture. Either you can put a balloon, as you can see over here, or you can take stitch and make the stomach small. So you put a balloon in the stomach, because of the volume, patient eats less, patient has an early satiety, and patient loses weight. When we take stitches into the stomach is a very roomy organ. We place stitches into the stomach, we make a stomach tube, so the capacity of the stomach goes down and patient eats less, and that is how patient loses weight. And that is what we do in these young patients nowadays. Both are effective, but stitching is permanent, balloon is transient. So this is what was a primer to what endoscopy nowadays do. Endoscopy is just not putting a gastroscope or colonoscope to see things, but now we treat tumors, we treat pathologies, not only the lumen, but what is also outside. Thank you very much.
Excellent presentation, sir. All the brief aspect of the therapeutic endoscopy. So any question from the audience?
Moving ahead, we live in difficult times, especially as far as the practice of medicine is concerned, because medicine is a science of uncertainty and an art of probability. तो अभी ये ज़माना है कि अगर पेशेंट अच्छा हो जाता है तो भगवान ने अच्छा किया, और पेशेंट बिगड़ता है तो डॉक्टर शैतान बन जाता है. So it is God who heals, but the doctor who charges the fees. So moving on to our next session, let us invite the chairpersons.
Next session, our chairpersons are Dr. Jignabin Dave and Dr. N.P. Kuadia. Jignabin is professor and head of respiratory medicine department at Government Medical College, Bhavnagar. She is also a dean medical faculty of Bhavnagar University, and she has also received TRO TB Oration Award in this year. Dr. Kuadia sir is a very senior medical officer, has been and retired from the health department of the government of Gujarat, and he has been ex-president, secretary, treasurer of IMA Bhavnagar, and also ex-president of Gujarat State Family Physicians Forum.
We start our session. I request Dr. Hitesh J. Bhatt, advocate and medico-legal consultant, at present practicing at Andheri, Mumbai, medico-legal consultant since last 23 years, medico-legal consultant of Vadia Maternity Hospital, Mumbai, medico-legal consultant of Central Railway Hospital, Mumbai, partner in legal firm B&S Medico-Legal Consultancies, past chairman Ethics and Medico-Legal Committee, FOXY. Authored books are Conscience in Obstetric and Gynec, Law Doctor Must Know. Author of website consentfordoctor.com. Invited as national faculty at many national and state conferences. Delivered more than 1,400 talks. Medico-legal consultant to 200 hospitals across of India. Served as officer bearer of IMA, AMC, MOGS, AFG, and he was the past secretary of our Indian Medical Association, Bhavnagar, and he is from Bhavnagar. Please give back apology for him. Life member of Film Writers Association of Mumbai. So he is not only doctor, he is also an artist.
Thank you for kind introduction. Yes, welcome Dr. Hitesh as a moderator for this very important and a different session at GIMACOM 23 at Bhavnagar. Now I would like to invite panelists for this panel discussion. First is Dr. Ranjit Chaudhary, who is as such a gynecologist practicing in Bhavnagar and done PGD MLS from Pune. Dr. Ranjit, please.
I request Dr. Dhanya S., Assistant Professor of Research, Coordinator of PG Diploma in Medical Law and Policy and Ethics, Gujarat National Law University. Dr. Dhanya S. is an accomplished academic with extensive experience in teaching and research. Community serving as an Assistant Professor of Research at Gujarat National Law University, Gandhinagar. She has amassed over 6 years of expertise in her field. Before joining GNLU, Dr. Dhanya worked as a faculty member of law at the Institute of Law, Nirma University. Her academic journey includes a doctoral degree where she conducted empirical research on the right of healthcare in India, focusing particularly on healthcare access in Gujarat. During her master's degree, she explored socio-legal issues related to surrogacy practices in India. Her areas of interest are encompasses constitutional law, health law, human rights, environmental law, gender studies. She has been actively involved in various research projects, including those funded at prestigious institutions like the Bill and Melinda Gates Foundation, MHRD, National Commissioner of Women, and Government of Gujarat. Thank you.
Next, I invite Dr. Vinesh Shah, if he is here. Please come on the stage. Okay. Now I would like to invite Mr. Hitesh Vyas, advocate practicing in Bhavnagar, civil and criminal courts. Mr. Hitesh Vyas.
This is an interesting session.
Thank you.
Medico-legal issues. I request now Dr. Hitesh Bhatt to start as a moderator of this session. Thank you.
Thank you, sir. I'm thankful to GIMACOM and all of you. So, good afternoon. See, usually when I say good afternoon, those who are awake and alive, they respond back. So, good afternoon. Okay. In my introduction, sir, usually you say that I have shifted from here to Bombay, but actually I have not shifted, I have just expanded till Bombay. My roots are still in Bhavnagar, and I am non-resident member of Bhavnagar IMA. With this, we will start that medico-legal cases are already increasing, demanding patients are there. As long as things are good between patient and doctor, this is the situation. But minute something goes wrong, they start dancing on patient's head, doctor's head. Why this was not done, why that was not done. So many questions. And everybody is doing this to the doctor, sir. This is what is happening today, right? So, I'm skipping this. So, medico-legal issues, we are facing so many issues in our practice. And this is the panel we already introduced. So, sir, a simple question, anybody can answer, where all a patient can complain? What are the avenues, what are the agencies, what are the institutes where our patients can complain against us?
Sir, there are lots of platforms where a patient can complain. Patient can complain to the local civil court, patient can go to criminal court, patient can go to consumer forum, patient can go to local like representative of the assembly, or they can go there also sometimes, and district forum also.
Medical council.
And
if you are lucky enough, patient will complain at all these places from one case only. So that is the misery. They are filing multiple complaints just to extract more money in consumer case, and this is what is the situation. So doctor may be looking like this from the front, but we only know what lies at our back, right? And that is why I'm not turning my back. Preventive medico-legal practice is always good. OC pills are always better than MTP pill. Being a gynecologist, I have learned this. So how can you prevent medico-legal problems? Madam, if you can throw some light.
So the first and foremost thing is to follow the proper consent thing. So like when I talk about consent, like all of you may know, if the patient is just walking into your clinic only for the purpose of consultation, so that itself is a consent. You can say that it's an implied consent, the patient is coming to you. But if it involves any other treatment, so maybe a surgery or any other special procedure is involved, so it is always better to go for a consent and explain everything properly to the patient, including the risk involved in the process and also the alternative methods which are available. So only after that you should make the patient feel that he is an integral part of the decision making. So you should not be taking a decision on behalf of the patient. So you should make them feel that they are the main part of this decision making process and properly explain everything and take the consent in a proper way. So communication matters a lot. Then the next thing is recording everything. So medical records, again, it's a very important thing. So if you record everything properly, even if there is anything goes wrong, so now even the court is of the opinion that if anything goes wrong in the operation theater or the operation table, it is not always the mistake of the doctor. So you should have proper documents with you to prove your case before the court of law.
Thank you very much. See, consent is very important, documents are very important, and consent taking is like, if all of you are married, you must have experienced this. In the evening, the wife asks, "Aaj sanjhe khawama shu banavu?" And you say, "Ke ખીચડી બનાવ." રાત્રે ખીચડી ખવાતી હશે તો ભાખરી બનાવ, એ તો કરાતી હશે. પૂરણપોળી કર, હવે રાત્રે કોણ ગળ્યું ખાય? આમ તો ઢોસાનું બેટર છે, એનું નક્કી હોય પણ પૂછે આપણને. That is what is consent taking. You know what to do, but you have to give alternates to the patient, and it should be looked or it should seem to the patient that they are in command and they are taking the decision. That is what is consent taking all about. And the worst mistake we are doing is consents are taken by juniors or nurses. Actually, consent taking should be done by the senior most good doctor who is good at communication. Hitesh bhai, in our practice, in our courts, how much is the importance of documents and consents? Do the judges, if properly consent is taken, if documents are proper, do they consider it in favor of doctor? What is the importance, legal importance of the consent?
આમાં સૌથી તકલીફવાળું એ છે કે જે ભણવામાં પ્રમાણમાં નબળો હોય છે ને એ વકીલ થાય છે, ખૂબ હોશિયાર હોય છે એ ડૉક્ટર થાય છે. પછી વકીલાતમાં થોડું આમ તેમ હોય ને એ જ્યુડિશરીમાં જાય અને એ નક્કી કરે કે આ ડૉક્ટરે કેટલો ફોલ્ટ કર્યો છે. સવાલ એ છે પણ આ બધાની વચ્ચે જે પરિસ્થિતિઓ છે એમાં જ આપણે જો ચર્ચા કરીએ તો કન્સેન્ટની વાત તમે કરી. કન્સેન્ટ છે ને એને ઘણી વખત એડમિશન તરીકે જોવામાં આવે છે કે પેશન્ટે સહી કરી દીધી છે, રિલેટિવે સહી કરી દીધી છે, દેટ્સ ઓલ, અમારી ડ્યુટી પૂરી થઈ જાય છે. પણ કન્સેન્ટ, ઇમ્પ્લાઇડ કન્સેન્ટ ડૉક્ટર પોતે પણ આપતા હોય છે કે હું, તમે મારી પાસે આવ્યા છો, હું તમને મારી પાસે બેસ્ટ અવેલેબલ જે સ્કિલ છે, જે અવેલેબિલિટીઝ તમામ છે એ બેસ્ટ રીતે પરફોર્મ કરીને તમારા શ્રેષ્ઠ ઉપચાર માટે બધું કરીશ. એટલે માત્ર કન્સેન્ટ ઘણા અલગ 3-4 પ્રકારની કન્સેન્ટ હોય છે, પણ એક્સપ્લિસિટ કન્સેન્ટની જો આપણે વાત કરીએ કે ભાઈ એકદમ સ્પેસિફિક કન્સેન્ટ, એ ટ્રાન્સપેરન્ટ હોવી જોઈએ, સેલ્ફ સ્પીકિંગ હોવી જોઈએ. તો એ કન્સેન્ટ જે તમે વાત કરીને કે ડૉક્ટરે પોતે કન્સેન્ટના કોઈ ચોક્કસ ફોર્મ ન હોઈ શકે, એ તો પેશન્ટ ટુ પેશન્ટ વેરી થતી હોય કે એની પોઝિશન પ્રમાણે.
So our Supreme Court had given decision in case of Samira Kohli versus Dr. Prabha Manchanda, what an Indian consent should be. It should be real and valid, it should be written, it should be signed by the doctor, signed by the patient, to witness, and consent is a contract. That is what the Supreme Court said. And we have confusion about language of the consent, right? What language? Ideally, the communication language should be the language which patient speaks. But when it comes to signing, it can be signed in any national or local language. You do not require it to be signed in a local language, or you do not require, because how many languages you will print the consent in? At place like Mumbai, we are getting patients from all over India. Can I print consent in 25 languages? It is impossible. One line should be added that since I don't know this language, this was explained to me in dash language. And it is presumed in law that if somebody who is of adult mind with sane mind with adult age signs somewhere, he understands and signs. So consent can be in any local or national language. NABH is teaching us to have it in 2 languages. Ideally, it is communication language which should be patient's language. With this, we'll move to some other question. This is a message, ultimate message. Good documentation is good defense. Poor documentation is poor defense. And no documentation means no defense in the court. If you don't have any document, don't expect any kind of defense. And what is consent? In 2 slides, I will tell you what villain is trying to do with the heroine in a Hindi film. Hero does the same thing. The only difference is of consent. I'm talking about marriage. So, in operation theater, so many things happens. You feel that something is under your control and it comes to you as a shock. Or sometimes you may kick the wrong ball, right? You cut something which is a vital organ. So there are so many types of mishap can occur in OT, and we have to be vigilant because a small mistake can lead to a big disaster, right? So we have to be very careful in OT. So now we are taking certain important aspects. If patient is on life support, can we remove life support of seriously ill patient with the consent of the relatives? Can we do that?
Sorry?
If patient, કોઈ પેશન્ટ ઓટીમાં છે, બહુ સિરિયસ છે, બચવાની આશા નથી, ખાલી વેન્ટિલેટર ઉપર જીવે છે, એના શ્વાસ ચાલે છે. સગાવાલા એમ કે અમે સહી કરી દઈએ, તમે આ બધા મશીનો કાઢી લો, મરી જવા દો બાપાને. Can we do that with the consent?
કન્સેન્ટથી માત્ર કન્સેન્ટથી તો તમે લાઈફ સપોર્ટિવ સિસ્ટમ રિમૂવ ન કરી શકો. એની લાઈફની પોસિબિલિટીઝ કેટલી છે એ તો ડોક્ટરોએ જ નક્કી કરવું પડે.
લાઈફની પોસિબિલિટી તો હુ કેન સે? પેશન્ટ વેન્ટિલેટર ઉપર છે, વેન્ટિલેટર વગર જીવવાનો નથી. વેન્ટિલેટર ઉપર છે તો જીવે છે, શ્વાસ ચાલુ છે, હાર્ટ ચાલુ છે, શ્વાસ અને હાર્ટ ચાલુ હોય એટલે માણસ જીવે છે. કેન વી રિમૂવ? એના સગા સહી કરી દે કે હવે મારી પાસે પૈસા નથી, મારે તો આ બધું કઢાવી લેવું છે.
જો પૈસાથી તો દૂર કરી શકાતું નથી, પૈસાના કારણે ન કરી શકાય. પણ જો એના ફેમિલીમાં કહેતા હોય કે હવે આમાં કોઈ સર્વાઈવલ ચાન્સીસ ઓછા છે અને રિમૂવ કરો તો કરી શકાય છે.
તો સાહેબ સર્વાઈવલના ચાન્સીસ ઓછા હોય તો આપણે મારી શકીએ?
મારી શકવાની વાત નથી. એને
કોઈના સ્ટેજ 4 કેન્સર છે, ભલે શ્વાસ પોતાની મેણે લે છે, એનાય સર્વાઈવલના ચાન્સીસ નથી, તો એનું ગળું દબાવી દેવાય.
નહીં, મારવા માટે મજબૂર નથી કરતા, પણ જ્યારે એ જ પૂછું કે પેનલ એક ડૉક્ટર છે, બીજાનો ઓપિનિયન લે છે, ત્રીજાનો ઓપિનિયન લે, એક કરતાં વધારે ડૉક્ટરના ઓપિનિયન આવતા હોય અને એવું નક્કી થતું હોય કે આમાં હવે આને વધારે કાંઈ મતલબ રહેતો નથી ટ્રીટમેન્ટમાં, એવું તો નક્કી કરી શકે છે ને ડૉક્ટરો.
મેડમ, તમારો કોઈ ઓપિનિયન?
So it's a matter of euthanasia. So as per the Aruna Schonbach case, the court has initially allowed the passive euthanasia, but it was not allowed for Aruna Schonbach. And there is a recent judgment of Common Course versus Union of India. So which has the court has put forward a procedure. So the doctors are, though people say that doctors are good, but you're not good, you cannot decide whether somebody survives or not. So here the issue is that you cannot take a decision even if the patient is terminally ill. So there is a process. The hospital needs to constitute a committee and they'll have to inform the situation to the collector. There is another committee constituted by the collector, and later on the collector himself will visit the hospital, and once he is ensured that the situation is very bad and the patient is terminally ill and there is no chances of revival, only after that the passive euthanasia is permissible. Active euthanasia is still not permissible in India.
And this report has to be submitted to JMFC and then ultimately court decides.
Yes, sir.
See, until it is a passive euthanasia, you can remove the life support with this system. Or if you want to avoid one committee, that is doctor's committee in private, patient has to have a living will. If patient has written in his will that you don't give me any exhaustive treatment if I fall sick to that extent, then that committee part can be removed. Still you have to go to collector, still you have to go to JMFC, and then only it can be removed. So this is how you can do it. Now, what is the practical way to do it, sir? Sir, practically apni hospital ma avu thyu hoy and still we want to do it. Is there any way to do it?
So we can take consent of the relatives and we can go accordingly.
Nah, consent ni to na padi. If you take consent, that means it is, you are killing it and you are actually creating a document also that you killed it. કોઈ પેશન્ટ એવું સહી કરી દે કે મને મારી નાખો, મને વાંધો નથી, હું સહી કરી દઉં છું. Exactly. The thing is, whatever MOU consent you want to take, you do. Recently what happened in Nanavati Hospital, they have in Mumbai, they shifted one of my friends who is an actor, whose father was there for 1 month, and He was not earning that much as much his father was consuming in that hospital. It was Nanavati hospital. So they discharged the patient against medical advice with the ventilator on at home, and they let that ventilator switch off at home. So the hospital will be safe. They have taken the discharge on ventilator, hospital is safe, and that is how they have done it. Even for small babies, if neonates are there, a patient can die on a ventilator. That's it. You can say that patient died on a ventilator. That is okay. But you cannot remove the ventilator because our law, section 299 of IPC says what is death or what is homicide. Homicide is to do something even to accentuate the situation which can lead to death, even if patient is morbid. And death actually is ultimate outcome of anybody's life, right? Death is the only outcome. Death is only permanent. So you cannot, and death, life itself is a lethal disease. It eventually leads to death. So you cannot kill anyone. So please do not do that mistake. Do not take consent and do not create document against yourself that upon a consent you have killed someone.
Sir, excuse me.
Yes.
Hitesh bhai. One thing that sir has raised very right question. What to do when patient is seriously ill? We all are discharging the patient under consent of left against medical advice, and we send the patient home.
But it should be sent with the life support. You cannot remove the...
yes, we are sending the patient with life support, and once the patient is at home, we remove the life support.
So that is what I said, yes.
Yeah, but that's what makes the death very miserable. And if you look at the palliative care medicine data, then India is the worst place to die in all over world. Just because we don't have any clarity on our legal part.
Yes, so that at present the law is premature. The Supreme Court has given decision in Anuradha Shanbhag case, as Madam has rightly pointed out. She has rightly pointed out the method, and that is the legal method. But only on such stage, both the lawyers are present. Usually it doesn't happen in the court, right? Ek party aave and ek no aave. Date pe date, date pe date. So that is the situation. Now if dead body is brought to my hospital, and I don't want to take that responsibility, can I refer that dead body to government hospital ke tyahan lai jao? Can I do that? આવું કરવું જોઈએ?
એટલે ડેડ બોડી અહીં આપણી પાસે આવે ત્યારે આપણે ડિક્લેર કરીએ છીએ કે ડિક્લેર થઈને જ આવ્યું હોય છે?
મરેલું જ છે સાહેબ, સગા નહીં ખબર છે, ગલતા નથી બાપા 1 કલાકથી.
સગા નથી સર્ટિફાઈ કરી શકતા.
સર્ટિફાઈ નથી કરતા તો શું, what should I do? Should I give some life support and send to higher hospital, or should I declare dead and I have to inform police and all? What should I do? Can I transfer?
પછી તો હાયર સેન્ટરમાં મોકલવાનો. જો ડેડ બોડી છે તો પછી હાયર સેન્ટરમાં મોકલવાનો સવાલ જ ક્યાં છે? તમે જ્યારે કન્ફર્મ કરો.
Exactly. So we should not refer dead bodies. That is the message I want to give. These mistakes we are doing and doctors are suffering. There is a case where a dead body was transferred and you cannot transfer a dead body. Whosoever receives the dead person, it is a cognizable offense if it is a death. Police has to at least do primary inquiry, right? There are sections for that in Indian Penal Code. So you have to inform police. Tell police that we have received a dead body of such and such person who is identified as this person by this person, and we are informing you, kindly come and do the needful. We can give the certificate of death. That means not death certificate which we know is a cause of death. But we can certify that this body is dead. There is no pulse, there is no BP, ECG is straight line. So we are declaring this body as a dead. We don't know the cause. Kindly come and do the needful. I'm going little fast, madam, so that we can include few more questions. Now, death on table. When death on table happens, there are so many things. If there is a cardiac arrest on table due to problems of anesthesia, what is the role of surgeon? Sahib, Ranjit bhai, what should a surgeon do? Cardiac arrest thyo che, anesthesia ma thyu che. What should a surgeon do? Anesthesia mari nakhyo, apne શું કરવાનું?
No, because ultimately the responsibility is combined because patient has died during surgery. So they have to try to revive the patient with the help of anesthetist, and if they need, they should call for some other help, or if it is possible to transfer with the revival facility, they can refer to the higher center also.
You want to add anything, madam? Okay. The thing is, not doing something is also negligence. Negligence has two parts. One is to do something which a normal doctor will not do, or not to do something which a normal or prudent doctor of your stature will do. So if you just wait and watch, you are not actively participating as per the surgeon's need, the anesthetist's need for resuscitation, you are still liable. So don't just become a spectator, help the anesthetist. Any which way your name will come. So don't worry about that, and you have to do whatever is possible. We are going further. Who gives fitness for anesthesia? We send patient for physician's fitness. Who gives fitness for anesthesia? Physician or anesthetist?
Ultimately, it is an anesthetist who gives the fitness because he has to give the anesthesia.
Exactly.
So he can take opinion of the physician, but ultimately final judge is anesthetist.
This is the answer. Physician gives certificate or assessment of the cardiorespiratory system. He just gives assessment of cardiorespiratory system. Ultimately, the fitness is given by the anesthetist. If physician says anesthesia can be given, still anesthetist can refuse. And physician says anesthesia should not be given, still anesthetist can find the way to give anesthesia, because if he will refuse, the other one will give. So that is the anesthetist who will decide about the fitness. In case of death, how important it is to inform the police? Madam, you will take it up first.
Sir, it is very important to inform the police. So I think before informing the police, the surgeon can, or the doctor who is in charge of the surgery can record everything properly, and he can also have a short meeting with his team, brief them about everything, and immediately after that he can inform the police. It is very important to inform the police.
Or he can give death certificate and release the body.
Sir, if it is a normal death, in that case
Death can't be normal.
That can be normal, but if it is if there are some comorbidities along with the issue which was under consideration, or it is normal, but it is always better to inform the police to avoid any further complications, because nowadays we see that even there are issues of the patients and their family attacking the doctors. So it's always better to inform the police.
Yes. Ranjit bhai, you want to add anything?
Yeah, it is better to inform the police, but when the cause of death is very clear, sometimes you can give the cause of death, but when the cause of death is in doubt, you should inform the police and they can proceed for the post-mortem examination.
સગા એમ કહે કે અમે સહી કરી દઈએ છીએ. અમારે પોસ્ટમોર્ટમ નથી
That is
કરાવવું.
not valid. If they have to do, we have to inform the police. They can sign in front of them police, and if police doesn't want, then it's okay for us at least.
Right.
I think so, to avoid any complications, it is always suggestible for the surgeon himself to even suggest for a postmortem.
હિતેશભાઈ, તમારો કોઈ ડિફરન્ટ ઓપિનિયન કે સેમ?
અનનેચરલ ડેથ હોય ને તો એને કરવું જ જોઈએ.
Exactly. So when the death is not expected, and we don't expect death, right? We don't expect death on table, or we don't expect death in most of the cases. ભલે stage 4 cancer હોય કે કંઈ પણ severe હોય તો બી we always wish that patient to come out. So we must inform police, because police under Indian Penal Code will come and inquire for that death. Now what is the role of police? It is not always a postmortem. One minute sir, let me complete. Police will never, it is not compulsory for police to get postmortem. It is like once you refer to the police. It is IPC 176 where they inquire for the unnatural death. Police will come and they will take opinions, they will take they will do panchnama, they will take the statement of the relatives. If they feel that there is no crime involved, they will not get postmortem done. If they want to get postmortem done, even if relatives are refusing, they will take the body, because it is their duty. Your duty is to inform the police. Now there are two benefits. First, if the cause of death is the same as you are thinking, you take the benefit of that. ધારો કે PPH છે, and the cause of death comes as PPH, you are right, so you are safe. If they give some other cause of death, you can always challenge, because you can say, because postmortem, the person doing postmortem is a different person. You can challenge that this cause of death is different, whatever we are saying is this. So at least if you can convince them, you can at least confuse them. And that is what in law you should do. If you can't convince, at least you should confuse. Right? So it is always better to inform police. હવે બોલો સાહેબ.
Ground reality is absolutely different. I have witnessed so many incidences when we ask for post-mortem, it creates conflict.
We should not ask for post-mortem. You change your words.
Even if you ask for police inform, the scenario changes.
You don't have to take anybody's permission. It is your statutory duty to inform police in case of unnatural death. તો સાહેબ પોલીસને તોય બોલાવવા પડે.
પોલીસ આવે તો તકલીફ વધી જાય છે.
Then
just a minute.
What message?
My suggestion is,
you understand We have to change with the situation.
Sir, we can take comments one by one.
My
Topic is
is-
very
Wait.
interesting.
What I am telling you from the stage is what we should do legally. Otherwise, whatever you want to do, you can do. There is no problem. I am here to make some changes in your practice with the tips which can otherwise trouble you.
Let me clear here.
My suggestion is, if high risk case explain mortality of say 50% or 40%, patient dies on table. If they are not willing to accept reasonable cause of death, then go for inform police.
So let police decide that. See, criminal case can be filed anytime. That also I will tell you.
Sir, in constraint of time, we can take some questions personally with
And
Hitesh Bhai and
sometimes-
all the panelists.
Yes.
But let me clear here that whatever procedure all the panelists and Dr. Hitesh Bhai is telling is, it is what is happening, what we used to do in our postgraduate studies or since our practice. All of us are practicing for more than 20 years now in Bhavnagar. But now what he wants to brief and what the panel wants to brief is what is law. What are adults? Because when anything goes to court, only the law will be followed. Not what you and me or anybody was practicing or is practicing. So it is what are the current laws and what should be followed, because otherwise nothing would happen. But in 1 or 2% of cases, if something goes wrong and the patients go to court, then only the existing law will be followed by the honorable court as well as the police.
Now-
so we would like to tell you the procedure which is actually now laid down to be followed.
See, nothing
I hope
prevents
I'm
you.
clear.
Nothing prevents you from giving death certificate. Understand that also. Doctors can give death certificate under Medical Council of India Act. You are entitled to give death certificate. You can always give. And that death certificate is cause of death. You can give. But you should not give. That is what I am telling. What you can do, that you should not do. There is a difference. So this is what we suggest as a medical legal consultant, that better get police informed. Don't utter a word of post-mortem. It is police's job. Once I refer a patient to neurophysician, it is his job કે એને એનું MRI કરાવવું છે, CT કરાવવું છે, જે કરાવવું એ કરાવે. Similarly, once you inform police, it is police's job what to do. But it is better to get it done. That is the message. Now, how to hand over the dead body? Suppose dead body is with the tubes in, with the IV line in, everything is there. Can we remove and give the dead body to the police? Or we have to keep it inside and we have to hand over the dead body? If you remove that, is it you are making some changes in the evidence? Is it so? It will be considered like that?
ના ના એવિડન્સના ફેરફાર ન ગણાય એને.
So this is the message I wanted to give. In one case where a dead body was given with the tube inside, surgery lasted for 6 hours. It was cancer surgery, some 6 hours it took. And when the dead body was given to the police, while shifting the dead body, that tube came into the esophagus instead of trachea. And the cause of death given by the in the postmortem, that tube was found in esophagus. So death can be due to that. Now, how can a patient survive for 5 hours with a tube in the esophagus? But it is very difficult to convince the judge on this point. It takes 5 to 10 years to make him convince about this. So it is better to remove everything and you can give. And why it is not amount to removal of the evidence from the crime scene? Because operation theatre is not a crime scene. We have no intention to kill. We are not taking patient there to kill. If you are killing somebody with intention, with knowledge, and you are removing something, then it is called the changes, or you are removing the evidence from the crime scene. That section will not be applicable here. You can always remove even dead body you can remove from the OT, because you have to take second patient on table. But once there is a murder and you change the position of the dead body, that is called removal of the evidence. That is taken against you if it is a crime of that nature. But here, court will understand this so that you can do it. And never let that blood and everything around. કારણ કે પંચનામું જે કરે police, what they write, PPH માં patient expire થયું છે, suppose it is placenta previa, naturally there has to be blood. પણ એ શું લખે પંચનામામાં? અંદર ગયા ત્યારે ચારેય તરફ લોહી 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 હતું. 5 વાર લોહી લખે. And that is why patient died. But that will make the impression of the other person very serious, right? And in blood, in delivery, is always mixed with amniotic fluid. 1 liter to fluid hoye. But they will say that. So it is better to clean up everything and then you send. It does not amount to mending with the evidence. So that is the message I wanted to give. Now, what immediate precaution you must take? I will take in one line. You tell your staff why patient died. Everybody, Drishyam 2 જોયું છે ને? Everybody should give same reason. કારણ કે ઘણીવાર એવું બને, you will say કે PPH માં મરી ગયું છે, પણ તમારા સ્ટાફ કહે કે આ મહિનામાં ત્રીજી વાર થયું, આ સાહેબ આવા જ છે, પગાર ઓછો આપતો એટલે ત્યાં પોલીસ સામે આવું બોલશે, રાઈટ? સાહેબ ઓક્સિજનનો બાટલોય નહોતો સવારમાં. આ બધું એ કહેશે જે તમે ઓલરેડી મેનેજ કર્યું છે. But they will give different statement and that can go against you. So first you make a meeting with your staff and tell them the exact reason the why patient died. And then જ્યાં સુધી બને ત્યાં સુધી તો એમણે મોઢું ન જ ખોલવું જોઈએ, પણ પોલીસ પૂછે તો જવાબ આપવાના જ છે. So it is better you first explain to them, then you explain to the relatives, and then you proceed further. Should I give death certificate? We have already discussed. We can give death certificate, but better we don't. Sir, is there any difference between criminal and civil liability of a doctor? Hitesh bhai, civil and criminal માં શું ફેર હોય?
ક્રિમિનલ લાયબિલિટીમાં એમને છે ને એનો ઇન્ટેન્શન દેખાતો હોય છે, તો એને ક્રિમિનલમાં લઈ જાય કે ડૉક્ટરનો ઇરાદો જ કાંઈક બરાબર ન હતો, અધરવાઇઝ એને ક્રિમિનલ લાયબિલિટીમાં ન લઈ જઈ શકાય. અને સિવિલ એટલે IPC 300 ગ્રોસ નેગ્લિજન્સ જ્યારે આવે ત્યારે એને કારણે જો કોઈ પ્રોબ્લેમ્સ થાય તો એને ક્રિમિનાલિટીમાં લઈ જઈ શકાય. પણ સિવિલમાં તો કેવું છે કે ડૉક્ટરના બોનાફાઇડ્સ ક્લિયર હોય, એવરીથિંગ ઇઝ ઓકે, પણ કાંઈક એવું થયું હોય કે જેને કારણે કોઈ નુકસાન થયું હોય તો સિવિલ લાયબિલિટીમાં એને લઈ જઈ શકાય. એમાં કોઈ ક્રિમિનલમાં બોનાફાઇડ્સ જોવાતા હોય છે, સિવિલમાં ક્રિમિનલમાં તો ડૉક્ટરનું એક્ટ જ તે મેઇન હોય છે.
Sir, please, we have only 1 minute.
Yes,
please.
Yes, sir. So when we talk about civil negligence, so negligence per se, so there are 4 Ds that you need to keep in mind. One is the duty of care, that like with the doctor-patient relation which establishes, so there is a duty of care. And the second one is there is a like breach of duty, or there is deviation or deficiency in the duty. So that is the second D. Third is there is damages. And the fourth one is there is a direct relation between the damage and the breach of duty. So this establishes the negligence. So that is civil negligence basically. And there was this case of Jacob Matthew versus State of Punjab. In this case, for the first time, the court said that the criminal to constitute a criminal negligence, there has to be a gross negligence. So this needs to be proved. Then only it is considered as a criminal negligence. That is why most of the cases it is not criminal negligence. It is not considered as a criminal negligence. Only if there is a gross negligence or recklessness on the part of the doctor, it is considered to be a criminal negligence.
Yes, Ranjit bhai.
So the basic difference is between criminal and civil is that is knowledge, act and intention. Whereas intention is not there in a doctor's case particularly, because he always tries to cure the patient. So like just murder or homicide, other homicide, intention is not there. He is doing the act. He has the knowledge that this act can be a dangerous or can be a life-taking act.
No, but at ground level, the difference, what I say is, the criminal case and civil case, there is a case of Suresh Gupta versus NCT Delhi where a gross word was added. Negligence has to be there in both the case. But negligence has to be gross. Now what is gross? The Supreme Court has given examples also. That giving wrong guess, operating on a wrong patient. So how I conclude a difference between civil and criminal is, when a complication which is not mentioned in your textbook, if that happens, it is usually a gross negligence, because no doctor is expected to do that. મને એક ચોપડી બતાવો જેમાં લખ્યું હોય એપેન્ડિસેક્ટોમી કે હિસ્ટ્રેક્ટોમીમાં ઓપરેટિંગ સીતા ઇન્સ્ટેડ ઓફ ગીતા, ફર્ગેટિંગ મોપ ઇનસાઇડ, ફર્ગેટિંગ સીઝર ઇનસાઇડ, ક્યાંય લખ્યું જ કોઈની બુકમાં? That is gross negligence. Then patient has a chance to win. If the complication which is mentioned in the textbook, which occurs in all over the world with some frequency, 1%, 2%, 5%, that is usually qualified
case for...
we are running
time over.
Yes,
so
sir.
Please
this is last message I want to give.
Thank you.
So this is a civil case. And if patient files criminal case in a civil complication, then you can go for quashing of that complaint. And whenever police is involved, it is a criminal case. So understand, and our medical indemnity insurance covers only civil case, not a criminal case. So whenever police is involved, be alerted, fight that with tooth and nail, because the punishment is ultimately jail. While in civil case, the punishment is the some pecuniary punishment, and that will be given by your insurance company.
Okay, sir.
So-
Thank you very much for our nice session.
So thank you very much, and we have to be very careful about medico-legal issues. Thank you. A big round of applause for my panelists. Thank you.
ડૉક્ટર માયાબેન અને ડૉક્ટર કોકિલાબેનને રિક્વેસ્ટ કરું કે ચેરપર્સન્સને ફેલિસિટેટ કરે.
Thank you for a highly interactive session, and I think we have all stirred up a hornet's nest. So discussion will definitely follow during the post-lunch hours too. Moving on to our next session, that is about happiness and laughter. So laughter, they say, is the best medicine, but you laugh without reason, you will need medicine. I would like to start with a very small anecdote. There was once a person who goes and visits a psychiatrist and complains that I'm very depressed, I'm very lonely, and I need some medications for it. So the doctor evaluated the history, and the psychiatrist said that you actually do not need any medications. You need to see a clown who is performing in the circus, and he's doing beautiful acts which will give happiness on your face. And the ultimate thing is that the person who was sitting on the opposite chair said, "Sir, I am the clown who gives happiness to everyone in the city, but I feel lonely and depressed." So that is the reality. When life on social media is gaining popularity and everybody is flaunting that they're very happy, we know in reality that doctors also need some healing. They need some happiness at the end of the day.